Good morning, everyone. I welcome you all to today's International CME on Advances in Pediatric and Adolescent Diabetes and Endocrinology. Let's start with the prayer. Shuklam Varadaram Vishnum Shashivarnam Chaturbhujam Prasannavadanam Dhyaye Sarva Vignopashante.
I am Dr. Kamala. Today's program will be started a little late than what was declared already. First, we will start with the introduction of the chief guests, followed by webcast at 10 o'clock, which will be a 1-hour program. Then follows the regular program of the CME. We want to do the introduction a little late when all the delegates arrive. So now we will start with the webcast.
Both enter a football pool run at the University of Washington. It's really $5 each for each submission. And Earl just showed me who he picked to win the NCAA championship, and that's enough about that. It was a mistaken identity of a team that's going to not go very far, but nevertheless, Earl's a Missouri guy, and picking Missouri to win the NCAA championship. It's just ridiculous, Earl. It's just ridiculous. So anyway, I just got back from the American College of Cardiology meeting in Orlando. And I was chairing a session which someone asked near the terminus of the session. The session was on diabetes and congestive heart failure. Okay, that's not typically a type 1 problem, but it's certainly a problem that the cardiologists see in type 2 diabetes. And the question was, what are the 3 things that a cardiologist needs to do before a patient with newly onset diabetes, let's say they've had type 1 and not really having everything tucked in, as you just heard. What are the 3 things you would do before they're discharged from the hospital? You're the consultant endocrinologist. Well, if you operate within a system that has an inpatient diabetes team, the team should visit the patient. Now, you may be the consultant endocrinologist and there's no inpatient team, but at the University of Colorado Hospital, we have an inpatient team that is staffed separately from the endocrine consult team. But if you don't have that in your system, then an endocrinologist should see every diabetic who's been hospitalized with heart disease, number 1. Number 2, clarifying discharge medications. That really is an important concept that the diabetes team relates to, but the cardiologists often can't keep straight all these diabetes medications. And the third, which relates to the session you just completed, is education. So often in the cardiology space, you have someone who has newly diagnosed glucose intolerance with an A1C that's elevated, and ultimately then diabetes education classes which relate to the psychology of management of new onset type 2 or even type 1. So those are the kind of the 3 things that we think cardiologists need to know about this. Now this talk is going to be focused on type 1 diabetes, and we're going to bring you up to date here with, I think, recent information that relates to this issue. And although you pediatricians don't think you have to think about this much, you clearly, I think, need to think about it because of some evidence we have that microvascular disease actually begins in childhood. So I really don't think any of these consulting boards, et cetera, have anything to do with what I'm going to talk about today. So let's begin with thinking about how an endocrinologist or metabolic physician thinks about atherosclerosis. Metabolic substrates, glucose, fatty acids, lipoproteins, inflammation, oxidation, or particularly for diabetes, glycoxidation. That's the end-link glycosylation of glucose on many proteins that relate to the atherosclerotic process. Endothelial dysfunction, which, by the way, is not atherosclerosis. If I gave you a high-fat meal, whether it be olive oil or a Big Mac, you would have endothelial dysfunction. It's simply a marker for risk factors that relate to atherosclerosis. And then the prothrombotic state, increased prothrombotic risk factors and defects in fibrinolysis. So I'm going to turn you to a paper that ultimately was written some time ago by Sarah DiFerranti at the Boston Children's Hospital, as a cardiologist, and myself and a number of co-authors, that I think is still pretty much up to date. And this is published both in Diabetes Care and in Circulation. So this is type 1 diabetes and cardiovascular disease. Now, what about, first of all, this is kind of where my career started in Seattle as a fellow. I kind of went there to work in the aspect of nutrition, cardiovascular disease, atherosclerosis, and diabetes. And one of my first projects there was working with the late Ed Bierman, who at that time was the division head. And basically, we were the first to kind of ask about lipoprotein distribution in type 1. A little bit of work had been done previously, but of interest, what we found was that in patients with type 1 diabetes, HDL cholesterols were higher. That's good, isn't it? And the ApoA1A2 ratio, and apoproteins were just coming into metabolic space at that time, was elevated. Now, historically, if you had increases in A1 to A2 ratio, you had large buoyant HDL, which epidemiologically seemed to be related to protection from atherosclerosis. Well, if you look at many cohorts going forward, the HDL cholesterol increase in type 1 is fairly typical. And to be honest with you, we really aren't still clear about the mechanism. But one thing we are clear about is that HDL may not be totally functional. How many people here know why high levels of HDL cholesterol are related to less atherosclerosis? If you know this, we can talk afterwards and I can really be updated on this whole issue. The epidemiology of HDL cholesterol and atherosclerosis is all there and good. But if you look at all the drug trials in adult medicine that have looked at drugs that raise HDL cholesterol, there's no benefit. So the epidemiology does not appear to relate to the HDL cholesterol level, but it presumably relates to function of HDL. And so this glycosylation of HDL, which is simply shown in this paper, but many others, probably prevents HDL from doing what it normally does. So when you measure HDL cholesterol in your patients with type 1 or without type 1 diabetes, don't make conclusions about modifying their HDL cholesterol pharmacologically. So the lifestyle factors that relate to HDL are the things we maybe should be more interested in, such as physical activity, leanness, alcohol, I'll pause there, and other things. So the more you drink, the higher your HDL goes, and people that drink a lot have less coronary disease, but they have lots of other problems too. So that's not an advocation for increasing alcohol consumption. All right, so I did the prototype of what's now called the Cacti Study, which we took about 150 people with type 1 diabetes and aged and matched controls. And then ultimately this ended up in a NIH grant that Marion Rivers, who's now the director of the Barbara Davis Center in Denver, landed, and Janet Schnell-Burgeon's taken over this project. But here's the study. The Cacti Study is called the Coronary Artery Calcification in Type 1 Diabetes Study. And the baseline exam was some 1,400 individuals, and half of those had type 1, the other half were sex and age matched. And they've been followed over a series of examinations over many, many years. So what we found from this cohort was ultimately that lipid levels are better in type 1 diabetes than they are in age and sex matched controls. Isn't that interesting? So if we look here at patients with type 1 who are in brown and age and sex matched controls, total cholesterol is lower, LDL cholesterol is lower, HDL cholesterols, although it doesn't look like much, they are higher because of the sample size, and triglycerides are lower. So what do you make about that? Well, lipids don't look so bad in type 1 diabetes. And then that was for women, and here we are men, and even those differences are a bit better in men with type 1 diabetes than in age and sex matched controls. By the way, these are all adults, and the study was designed to look at whether coronary artery calcification related to risk for atherosclerosis, and then ultimately going forward, whether progression of coronary calcification over time, over this 12-year interval, would impact events, too many events expected maybe to have information there that's valuable, or in fact related to atherosclerosis-related risk factors. So here's the search study, and ultimately I'm going to point out one thing about this slide. If you have less good control shown on the right with a dark black bar, or the gray bar, which is A1Cs less than 7.5, you tend to have, I'm sorry about the pointer, it's really not working very well, but anyway, the LDLs with poor control tend to be higher. Small dense LDL seems to be more prevalent. Triglycerides only in the poorly controlled group are higher, but in fact the HDL cholesterols are still, if you look at the numbers, less than 35, which would be considered an arbitrary level of HDL we relate to risk, are actually still better in this search study, which here is a large number of younger people with type 1 diabetes. You can see the sample size actually is I guess, a little bit less than it was in Cacti. So, okay, so in poorly controlled diabetes in type 1, yes, lipid abnormalities may be more common, but in most situations where A1Cs are typically 7.5 or 8 or so, it doesn't seem to be problematic. So the take-home message here is HDLs or high HDL cholesterols are higher in type 1 diabetes, but ultimately, as we look at the function of HDL, we're not sure how it works. There's 6 or 7 mechanisms that have been described. We're not clear of the benefit. So for your pediatricians, here's something to think about. And atherosclerosis is present early in children with type 1 diabetes. And what you're seeing here is you're seeing the control group on the left, and you're looking here at carotid intima media thickness and aortic intima media thickness. And ultimately, patients with type 1 don't look all that different than patients with familial hypercholesterolemia. So we know FH is a disorder of the LDL receptor or other mechanisms that relate to LDL cholesterol levels. And ultimately, plaque begins early in people with FH, and patients with type 1 seem to get a head start when compared to young people without diabetes. And this is really just after 4.4 years of duration. Now, we could go on with a list that's 20 or 30 papers long in terms of this increased relationship between type 1 diabetes and atherosclerosis. And these are simply some of the studies that have been reported here in the space. So what do we know about atherosclerosis in type 1 as to whether it's the same process as it is in type 2? Now, I have somewhat of a bias here, partly because of data we've had from Cacti, but also some evidence from pathological samples. So is the plaque the same or is it somewhat different? If you think about risk factors for atherosclerosis in type 1, I showed you the lipid data. Typically, you're not overwhelmed by the lipid data as being predicted. And blood pressures, yeah, more hypertension, but generally leanness is relatively present, and we know that insulin action initially is probably pretty normal, but maybe there's some insulin resistant component. But nevertheless, ultimately the data I'm going to show you in the next couple slides relate to the fact that the plaque may not be the same. And Sarah DeFronti et al. With us really described this in more detail in the paper I referred to earlier. So here, if you're looking at atherosclerotic lesions that are greater than 1 millimeter, there's more per lesion when type 1s here are age 46 with 23 years of duration. The type 2s are age 50 with 8 years of duration. So the age is a little bit less in type 1s, but not much. If you look for any given plaque area, ultimately the plaque burden is higher in patients with type 2 in the dark bar versus the lighter bar in type 1. And overall, what we're seeing is on the right, particularly what I want you to pay attention to, is that the plaque is more calcified. So for any given plaque burden, there's 50% of that plaque is calcified, whereas in type 2, much of it is not calcified. Now, I'm not going to spend a lot of time on the atherosclerosis process, but when you get cholesterol in the arterial wall, that creates inflammation. And how do you heal inflammation? With fibrous tissue and calcification. So the idea that the plaque in type 1 may be more calcified either simply indicates that inflammation is more rapid and more capable of creating a stable plaque, or maybe in type 2, just the cholesterol content of the plaque in some way is maybe creating ongoing inflammation for a longer period of time. We really don't know, but keep in mind, calcified plaque tends to be stable plaque. And the thing is, what we need to think about is ultimately whether coronary calcium gives us the real story about whether or not the plaque is really favorable or unfavorable when it's calcified. We know calcified plaque simply represents plaque burden. So the more calcification you have in your coronary arteries, the more plaque burden you have. But the question comes up as to whether the calcium itself really represents risk, and we know that maybe it's not the entire story. So what about assessing the presence and progression of atherosclerosis in patients with type 1 using coronary calcium scores? And I should point out, if you look at risk factors in adults for cardiovascular disease, and let's include diabetes as one of those risk factors. If you look at age, sex, HDL cholesterol, total cholesterol, systolic blood pressure, and diabetes plus or minus in smoking, those are all the conventional risk factors. There's only one thing that changes your receiver operating curve for predicting events, and that's the calcification score. So that's kind of the major tiebreaker for assessing need for statin therapy in adults. So this calcification score could, in fact, merit more serious attention in type 1. So when we did the first study, Donna DeBallia's publication here, looking at coronary artery calcification scores in patients with type 1 diabetes of 23 plus or minus 9 years of duration, again, age and sex match controls, you're pretty underwhelmed. I mean, women, basically have less calcification than men to begin with. That's shown by the comparison of the right bars with the left. But if you look at patients with type 1 diabetes and Black, I mean, as you progress from left to right, yeah, in men, scores between 20 and 100 or greater than 100 were more common. And in women, even above 0 were more common, but it doesn't knock your socks off, does it? I mean, 75% of women with 23 years of type 1 diabetes had no calcification, and 60% of men with type 1 diabetes for 23 years had no calcification. But then, remember, the study was designed to look at the progression of calcification. So if you look at skin, collagen, advanced glycation end products, or ages, they related to progression of calcification. John Hokinson's work on the haptoglobin gene, ultimately the frequency and progression of periodontal disease related to progression of calcification, lipoprotein-associated phospholipase A2 related to it, paired renal function, ultimately uric acid, work by Rick Johnson et al. Anyway, so if you keep looking at all these kinds of things, they all predicted calcification increase. But the question came up, is an increase in coronary artery calcification alone, does that predict events in patients with type 1? And perhaps it's plaque density. And to summarize some recent radiographic imaging information, is that if you have more calcium per any plaque volume, the density of the plaque, not the amount of calcium, the volume, but the density of the plaque, ultimately the density of the plaque is protective against events, because I think it relates for any given plaque area, more stabilization of the plaque. And interestingly enough, if I treated all of you with statins and we got a baseline coronary artery calcification score, and let's say it scored, you weren't 0, ultimately an increase in coronary calcium would be expected. And I think because of cholesterol lowering, what happens in the plaque is the plaque becomes more stable, and remember, we heal inflammation by calcification. So the idea here is let's keep cholesterol out of the artery. And in diabetes, if in type 1, because LDLs are basically pretty normal, what's this process all about? And I think we've got still a lot to learn about that. So again, just one article by Matt Budoff's group suggesting that the density of the plaque may be relatively protective for any given volume. Let's turn to glycemic control now. We look at the Danish cohort, and by the way, a lot of this is epidemiology. In fact, almost all of it's epidemiology in type 1. So here, if you look at various gradations of quartiles of A1C, only when you compare the top quartile with the fourth quartile, A1Cs between, look at those quartiles, 5.5 to 8, 8 to 8.7, 8.7 to 9.7, and 9.7 to 14. It's only statistically significant when you compare the first to the fourth quartile in terms of how glycemia impacts in the Danish cohort mortality, and most of this is type 1 diabetes and atherosclerosis. So what about more recent evidence of intense glycemic control and all-cause mortality? Well, here's the Swedish cohort. The Swedish is a large registry. Don't you love the Scandinavian countries? They have databases on everybody. And we have, 25 to 30,000 people with type 1 diabetes. Boy, we got something to envy here in the United States, don't we? So the primary objective here is to examine the cause of death in patients with type 1 and related levels of glycemia. So this is 33,000 patients with type 1 and 165,000 controls matched for age and sex. The follow-up here is a 14-year follow-up. 1,500 AMIs and CHDs, and I might pause here a second. The cardiology community clearly has trials defined on numbers of events, not relative differences between groups. I mean, there are good examples of that. If you look at UK-PDS in terms of metformin and how many events showed protection from metformin, 41 total events. If you look at saxagliptin, the early data that was reported with saxagliptin and coronary events in patients with type 2, there were only 38 events. But boy, cardiologists get really nervous. And here we're looking at 1,500 AMIs. Now keep in mind that these are observational data. There's no intervention here. So in the controls are matched controls with 1925 events. So here's this gradation of effect of ultimately levels of relative risk based on age. So the ages are shown on the left and the relative risk for men and women. Pretty impressive relationships between type 1 diabetes and age and sex match controls. And that related for other risk factors, including hemoglobin A1C shown at the top. On the left is any form of albuminuria. And the third set of bars is EGFR. So renal function and proteinuria and A1C all appear in the Swedish cohort to impact outcomes in terms of myocardial infarction or coronary heart disease death in this cohort. All right, now, what about pumps versus MDI? We've heard a lot about that yesterday. And here's, again, more Swedish registry data. And to simplify a very straightforward slide, if you're on a pump, you do better. And this is for non-fatal coronary heart disease and total mortality. And that related in part to A1C, but not entirely the hemoglobin A1C. And that also related to both ischemic and hemorrhagic stroke. So you're seeing the gradation on the left that ultimately looks at the impact of various levels of glycemia on stroke. So we have that same relationship to other forms of the atherosclerotic process. Of course, we all would argue that hemorrhagic stroke is not really atherosclerosis, it's more hypertension related, but typically stroke is only 20% of CVD outcomes in the carotid system and above. All right, so now we're going to look at data from the United States. This is the DCCT, the Diabetes Control and Complications Trial. As most of you know that trial well, you should know it if you're in this room. Was a 7-year intensive management of fairly newly onset type 1 diabetes that looked at the impact on microvascular complications. And I presume Jan is going to talk more about that in the next presentation. But ultimately now, as you follow these people 30 years after the intensive control, ultimately you see a splay in these graphs indicating that with better control, ultimately there are less events. Now keep in mind, this is a legacy effect, because the intervention was only for 7 years, but yet the outcome is measured now at the 30-year interval. And the initial publication of these data related to 100 events defined up front. But now as the trials continued further and the EDIC follow-up, ultimately now the increasing evidence is that having 7 years of outstanding control, despite the fact that after the 7-year intervention, there's no difference in hemoglobin A1C, there's an effect that goes forward. Now, if you look at this, I'm going to take off my glasses here. What we're looking at here is the impact of a 1% increase or a 1% decrease in A1C on the outcome. And you're seeing that in general, a 1% A1C change on these events to follow impacts it in both directions in a favorable and or unfavorable manner. One thing that didn't come up last night is that despite my 65 years of type 1 diabetes, after the DCCT came out, I took my own disease more seriously and I really tightened up my control. And you know, when you take people whose A1Cs are higher and you really aggressively manage them, which I did, I developed proliferative retinopathy on one side and macular edema on the other. So I've had, you know, focal coag on the macular side and also pan-retinal on the other. So these slides are put up, only part of the slide can you see, and it's a little hard to type. So my vision, even though I have these progressive lenses, is not all that great. And when the slide doesn't fill the entire screen, which it's not, ultimately it makes it a little difficult to see. So I apologize for that, but I didn't bring that up last night. It's too much about Bob and not about the science. But anyway, so bear with me if I don't seem to be able to see everything so clearly. All right, let's go forward. Okay, so we're looking now at the ability to predict cardiovascular disease events in type 1 diabetes. So here's the Steno risk engine coming from the Copenhagen, the Steno Diabetes Center there. And they used 11 variables that predicted the 6 to 8 year risk ratio of 18.4% with an overall C statistic that was pretty good at 0.6. Now, keep in mind here, a couple caveats. 11 variables that predict risk over a fairly brief period only represented 18% of that risk availability. So in other words, 80% of the risk for a cardiovascular disease event in patients with type 1 could be predicted by this risk engine. So if you look at this risk engine, those things that really stood out, I think, beyond the usuals like age and EGFR and male sex, et cetera, were microalbuminuria and macroalbuminuria. Now, I believe very strongly that microalbuminuria is not kidney disease. If we got spot urines on everybody in this room, you might have a bit of microalbuminuria today and won't have it tomorrow. I think what it is, it's a leaky basement membrane. But people who have microalbuminuria are more likely to progress to gross proteinuria. But in this risk engine, having microalbuminuria ultimately related to cardiovascular disease events. So I think it does relate to a generalized capillary defect in type 1 diabetes that means your capillaries are leaky and you're leaking albumin in small quantities into your urine as the metric for a leaky basement membrane. So look at some of these other things. Type 1 duration, 1.14, A1C, 1.13, LDL cholesterol, look at that, 1.09. I mean, look at these things. Not very impressive. But then John Hokanson and I, he's in the School of Public Health, wrote this editorial, The Prediction of Atherosclerotic Cardiovascular Disease and Type 1 Diabetes. Do we just stop here? How many people can define clinical trials that are randomized in nature in type 1 diabetes that have looked at blood pressure control or lipid modification? And of course, the A1C is all observational. Nobody's anymore going to do a trial where we're going to target A1C to less than 7 versus 7.5 to 9. And I don't know whether you internists or adult endocrinologists have seen this, but the American College of Physicians stated a statement last week, under 8 is perfectly acceptable for patients with diabetes, not distinguishing type 1 and type 2. Well, fortunately, the ADA, the Endocrine Society, and many other organizations responded to that to say that that's not good general recommendations for practicing internists. So just to point out something simple. Now, here's a fairly recent paper that looked at electrocardiographic abnormalities. We're talking about non-specific ST and T wave changes, those things we ignore. They looked at QTC prolongation. They looked at supraventricular rhythm disturbances like PACs, et cetera. Any type of disturbance on a baseline electrocardiogram, look at that risk difference over time. So that's not saying you should all be getting ECGs on your patients every year, et cetera, to look at this as a predictor. It's just another thing that might have some relevance in terms of patients and assessing risk going forward. If that ECG happens to be done, randomly and you see this kind of thing, you might just pause a second and think about taking steps to assess risk factors more aggressively. Now let's turn to the issue that we're all confused about, at least I'm confused about it. What about statins in patients with type 1 diabetes? Well, if you look at the heart protection study, which included 5,900 plus patients with diabetes. Now, this is all kinds of diabetes. And most of the clinical trials with lipid-altering therapies really did not distinguish very well from type 1 and type 2, although they claimed that type 1 diabetes was a relative or absolute exclusion. So again, I wish I had a pointer, but on the top, the data for type 1 diabetes. Look at that point estimate and the confidence intervals around that point estimate. Basically, what the data show is if you have type 2 diabetes or no diabetes, the benefit of statin therapy is equal, if not better, in type 2 diabetes. But look at type 1. Now, what kind of conclusions can we make from that point estimate with a large 95th% confidence intervals that surround it? And here, blowing up a little bit more, now we're looking at coronary heart disease events. This is the cholesterol treatment trialists. These are 26 trials with 170,000 participants. So this is not the heart protection study. This includes the heart protection study with many other trials included. And look at that point estimate. Yes, it's 0.77, but the 95th% confidence interval is 1.01. Can we, with that small sample size, can we make any conclusions about this? I don't think so. Now, let's turn, to the Swedish registry. Have we looked at that before? Anyway, 24,000 patients with type 1 diabetes who had no history of cardiovascular disease. They were followed up to December 31st, 2012. 18,000 were untreated with statins, and 5,000 were treated with, by the way, I should pause, lipid-altering medication. But 97% of the lipid-altering drugs were statins, not fibrates or niacin or ezetimibe or other treatments. Okay, so here's Here's the statin data that we have to live with. So if you look at this, forgive me a second. So triglycerides were a little bit higher in the statin-treated patients. I find that kind of interesting. These are baseline data, but the LDLs and the HDL cholesterols were the same in those that had been untreated and those that were statin-treated. So here's the data we have in type 1 diabetes. Those people on statins in the blue line versus the red ultimately had less death being on statins versus those that were not. Now, what's the problem with this type of analysis? People with type 1 on statins, people with type 1 not on statins. Should be an easy answer. Nobody's saying anything. Nobody wants to be. Anyway, so the problem is how well matched are the people who are on statins versus those who are not? I showed you triglycerides a little higher in the statin-treated group, but I didn't show you everything else. So if you look at all forms of outcomes that relate to atherosclerosis shown here, they were all benefited in statin-treated patients. But what if you match the people who were on statins baseline with every other risk factor we know that relates to atherosclerosis and type 1 diabetes? And here's what you find. Wow. No clear benefit. So does that mean statins are not beneficial in type 1 diabetes? I don't think we can say that. But it does say in an observational study, when you match the cohort on statins with the same number of people who have the same baseline risk factors that have type 1 diabetes without statins, we don't see any difference. Maybe the interval was too short. Maybe the dose wasn't adequate. By the way, can you imagine a paper like this being written without the dosage of the drug being given? Was this 5 milligrams of pravastatin or was this 80 milligrams of rosuvastatin? We don't know, but you can only speculate that dose may have been an issue here. So let's see what we can conclude about statins. The benefit of statins on cardiovascular disease and type 1 diabetes demonstrated, however, it's observational. The matched cohort had a markedly reduced benefit, and the exclusion of high-risk treated type 1 patients with CVD, where greatest benefit of treatment would occur, needs to also be considered. There may have been people with type 1 diabetes and cardiovascular disease already, where in fact a benefit for secondary prevention may have ensued. The statin doses and degree of LDL lowering was not identified in the paper, and unknown confounders were really not identified. So we have a real problem here making any decisions. Am I on a statin? You better believe I am. But that's an N of 1, and I'm not dead yet. So anyway. In this recent paper, pediatric endocrinologists may have seen this. This is an intervention where both statins and ACE inhibitors were given in type 1, and they measured carotid intima media thickness and hsCRP, and there was no clear benefit. So young people with type 1 diabetes who are given statins and an ACE inhibitor to see if we can modify cardiovascular disease risk, no hint of benefit, meaning no change in CIMT and no change in an inflammatory marker, hsCRP. Again, young people, maybe it's too early, maybe these things aren't really abnormal at that age, and of course there's not much change in CIMT at the younger age, but nevertheless, I think it's a message that we need to heed going forward. Now, interestingly enough, in type 2 diet, let's take the patient with pre-diabetes who is in the adult space, and he or she has an A1C of 6.3%. We know that statin therapy in people with pre-diabetes in the adult space have an increased incidence of new onset type 2 diabetes if you use a threshold of 6.5%. Now, that's about a 10% risk in people with so-called pre-diabetes in terms of developing type 2. But don't ignore the fact, and Earl may argue that a 0.2% increase is not relevant, and I don't think it is in terms of clinical management. You know, your glycemic management strategies don't need to change if you put a patient on a statin, but nevertheless, it does go up a little bit. And so the whole issue in adult medicine with pre-diabetes is that what's the mechanism by which statins modestly modify glycemia? And it's been implicated as being mainly a beta cell function because the cholesterol pool size within the beta cell does relate to glucose-stimulated insulin secretion. But in type 1, the beta cell is not working. So maybe it's something beyond the beta cell. So kind of a mystery, but the impact is small. But don't be surprised if your A1C in your adolescent goes from 7.4 to 7.7 if you start a statin because they're relatively hypercholesterolemic. So what about guidelines? Look at those in terms of advice to take home. The National Lipid Association, ACE, the Endocrine Society, And the ADA basically have no distinction between type 1 and type 2 diabetes. And the American Diabetes Association and the European Association for the Study of Diabetes say most type 1 patients greater than 40 years and younger, if they have nephropathy or other risk factors, should be considered for statin therapy. Well, your choice. Now, the Canadian guidelines, so you have a little bit more information. All patients with diabetes who are greater than 30 years with 15 years duration or age greater than 40 with microvascular disease, advanced kidney disease, or hypertension should be treated. I don't know about you, that looks like vegetable soup with me. Look at all those criteria in there that you need to think about. But nevertheless, the Canadians have put a step forward, again, based on relatively soft evidence, but nevertheless, they have taken a stance, excuse me, in statin management in type 1. So here's some other things to consider. This is RHE, that's yours truly, so take it and trash it if you want. But I think secondary prevention, meaning a patient has an atherosclerotic event with type 1, you got to follow the existing guidelines. And that would be for anybody that's had a cardiovascular disease event. For primary prevention, at least moderate intensity statin, which would be 10 or 20 of atorvastatin or 5 or 10 of rosuvastatin. Here's my thoughts. 20 years of duration of type 1, age 30 with any additional atherosclerotic risk factor. Are my boys on statins? No, and I don't want to enter into the last conversation in terms of dad and kids with type 1. Anyway, we'll leave it there. Coronary calcium score greater than the 75th percentile. And then you say, well, when should I get a coronary calcium score? As a tiebreaker and someone you're thinking about giving a statin, may be enough information to make that decision more certain. Age 20 with an LDL greater than 130, I think is another time to think about a statin therapy in a young person with type 1 with a goal LDL of under 100. And special consideration always with statin therapy in women with or without type 1 diabetes is the whole reproductive issue. Now, more Swedish data, I'm going to end with this. So the Swedish registry has recently defined more clearly what they think CVD risk factors are. So we're talking about a blood pressure that's greater than 140 systolic or greater than 90 or 80 here diastolic. Let me point out here just for a second that if you look at the quartile ranges in their population, 114.2 and 143 are between the first and second and third and fourth quartiles. Now, the ACC and the American Heart Association have just come out with new blood pressure guidelines. We've redefined hypertension for the 90th time. So, but above what, I was in medical school, 120 over 80 was a normal blood pressure. Isn't that what you all learned? Anyway, so now 120 to 130 is called elevated blood pressure, and 130 to 140 is called stage 1 hypertension. So here, the Swedish criteria of above 140, I think, is pretty generous and probably irresponsible in terms of our current age. An LDL above 116, smoking, of course, is always a risk factor. Albuminuria defined as micro or macro, and an A1C greater than 53 millimoles. I can't think about A1C in millimolar, I'm sorry. But anyway, that's greater than 6.9%. All right, so here we're looking at how many of these risk factors are ultimately elevated based on in the fourth quartile, and look at that gradient effect. The more of those factors in type 1 you see, the greater relationship to all-cause mortality. And that's also true of acute myocardial infarction. So I think what this, and here's actually hospitalization for congestive heart failure, which is an important space now for SGLT2 inhibitors in patients with diabetes, or now the data which I heard at the ACC, the cardiologists are starting to get into the SGLT2 space in the absence of diabetes, looking at the benefit of the SGLT2 and modifying the natural history of congestive heart failure. So I think risk factors really should define your approach to more aggressive lipid management and blood pressure management. And I think although there are limitations in generalizability from the Swedish cohort, it's probably the largest and best observational epidemiological study we have, and we need to be more aggressive in controlling all CVD risk factors in our patients with type 1 diabetes. And outcomes are improving, as shown here again in Swedish data, both mortality and morbidity in both types of diabetes. And ultimately, this shows that benefit in type 1 of 20 years duration with matched controls. And look at the top bar, type 1, and the bottom bar, boy, that difference between age and sex match controls is still substantial. And we know that now type 1 diabetes, boy, end-stage renal disease is less common. Retinopathy and blindness, meaning progressive retinopathy and blindness, less common, but yet cardiovascular disease still has a substantial outcome that's not in the favor of having type 1 diabetes. And I think we need to pay more attention to this area. So let's conclude. My talk today said that type 1 diabetes is associated with at least a 2 to 3-fold increased risk of atherosclerosis and events and related death. But is the pathophysiology the same? I'm not sure that it is. Yes, there's lipid accumulation, inflammation, but more calcification may give some relative protection versus type 2, where the plaque is less dense and probably more vulnerable. Improved glycemic control almost certainly reduces ASCVD and all-cause mortality. And by the way, the cardiologists have this very, I'm generalizing here, but for the most part of this very narrow view in type 2 that control is totally unimportant. It's not true. In type 2, even the aggressive insulin management strategies have shown maybe a 10% reduction in events. But the new space and the GLP-1 receptor agonists and the SGLT2 inhibitors really do demonstrate that there are mechanisms that are independent of glycemia in type 2 diabetes. But I think the evidence we have in type 1 is pretty convincing that glycemic control is relevant to macrovascular complications. And I think with greater durations of type 1 and age, other risk factors such as proteinuria and decreases in renal function become increasingly important. I've not shown you the data because it's not published yet, but I can assure you there's a very important paper that will ultimately be seen in press that relates to these other factors as being much more predictive beyond glycemia in type 1 diabetes going forward. I just wanted to show you a picture from my deck. I live at 7,300 feet southwest of Denver, and Earl can show his Seattle pictures all he wants. But, you know, in Seattle, you never see sunsets because the clouds and the rain protect you from the sunset in the evening. So, Earl, do you want to come up and defend yourself here? Anyway, so thanks so much for your attention. I hope this has been helpful.
Teachers and friends, welcome to today's continuing medical education program on pediatric adolescent diabetes with little bit of endocrinology. Before our two chief guests are introduced, I want to acknowledge the presence. Please, Raghupati. Professor Raghupati is the one of the senior most pediatric endocrinologists of the country, virtually one of the founder, but he has an Australian connection. Okay, and he did the work there, and Bruce and Angie will be introduced by them, and we have several senior doctors, counselors. Due to time, we will introduce as it goes by. Dr. Sharada is the senior member of the team. We have a bunch of people doing full-time endocrinology, we have counselors. We have some students and young consultants from other parts. We will introduce each other. We want to keep up. Kamala is the timekeeper. Okay, now we start. Can you introduce this? Yeah.
I've only recently met Mrs. Angela Middlehurst and Professor blank mind, Professor Bruce King 2 days ago. I haven't looked up the details of the CV and other things, but let me first introduce Mrs. Angela. Can I call you Angie, please? Angie, yep, okay. Angie and I struck a wonderful rapport 2 days ago because Angie hails from an area where I started my career in UK and also finished my career in UK. She's from Middlehurst, Middlesbrough. She's from Middlesbrough, and she says that's a rubbish place. It is. But there are very many beautiful parts of the villages there. around Cleveland in North Yorkshire. It's not North Yorkshire. It's been divided into North Yorkshire. Yorkshire has been divided into Cleveland and Yorkshire. And the great thing about Middlesbrough and a place called Great Ayton is that Australia was discovered by a chap who hails from Great Ayton, that is James Cook. And I happened to work both at the James Cook University Hospital in Middlesbrough and Northallerton, and she felt that it was wonderful that I know places like that in Yorkshire. Angie is a pediatric diabetes educator, and she has experience in less resourced countries, diabetes in school, and camps for children and young people and with diabetes. She's a registered nurse, isn't it? And what is RSCN? It is a state children registered sick children nurse. Okay. I don't know more about her, but it's a pleasure meeting her. We had a long chat, and I wish to continue the chat after the classes. Yeah.
Difficulty downloading their CV. Their websites in their hospital are so secure. Both of them cannot access their emails from India. So only we got to know Angie through the International Diabetes Federation, Life for a Child with Diabetes. She is a senior person in that, works with Dr. Graham Ogle, whom many of you have met. She's very young. She will tell her age herself. She's supposed to retire and she's not retiring. Okay. And
now. Professor Bruce King, it's a pleasure to welcome you and of course you too to our country and Bangalore and this seminar here. It's a great honor to be what you call be associated with you. I must tell you, his name is Bruce King. I don't know if you all heard about King Bruce. Have you? Yeah. King Bruce of Scotland. And those of you who do not know, there's a little story. Are you Scottish? Okay. So King Bruce he fought the English 6 wars trying to kick them out of Scotland. Every time he failed. And then in desperation, he went and hid in a shed, a cold one. And he was lamenting his disasters and misery when he saw a spider jumping from one beam to the other beam in the shed. It tried 6 times. Each time it fell off before it could reach the other beam. And finally, he was really praying for the spider to succeed too. And in the 7th attempt, it jumped to the other beam and finally wove its web. And that inspired him. And he then fought the English again and won this time on the 7th attempt. So that's King Bruce, and you are Bruce King. It's a good association. The Professor Bruce King works in Newcastle as a pediatric professor, and his main thrust is to make the lives of children, control the diabetes in children very well, to see that they have good quality of life, and to also support the family. Towards this end, his main, what he calls studies are now focused in what he called devising an algorithm to make better use of the closed insulin artificial pancreas, which he calls the bionic pancreas, I'm told. Is that true? Do you call it the bionic pancreas? Yes. Pardon? Right, yes. And for the collaboration, he's got an engineer friend. I don't know who he's a laureate. He's a professor. He trained at Imperial College in London. And he was the youngest professor at the age of 26. What's his name? Graham Goodwin. So he's working on the algorithm, is it? And the algorithm is called Scenic. What difficulty they're having with that is that the postprandial, that is after meals, blood sugar and after exercise with the algorithm they have is not satisfactory. Is that correct? But that's his trust now. That's where he's working. Apart from very many papers he's published. So welcome to Bangalore, Professor Bruce King and Angie. Thank you very much.
Only one point to add is he takes care of about 600 children plus in Newcastle, plus outreach about 300, 400. His children average HbA1c 7.1, the highest in the best in Australia. Am I correct? Okay. And there is one person, stand up. Okay. She's the heart and soul of type 1 diabetes in this country. She is Ms Chugh. I tell them, if she speaks, people cry. She speaks from the heart. She has type 1 diabetes. She is a peer leader. She is a doctor. And she runs the education program of the CDIC in Novo Nordisk. I can't find anybody who puts, who knows the inside and outside and cares for the people. She has 4,000 plus children she's taking care of. Okay, sit down. I'm really glad to see Professor Raghupati. It's a real thing. You have to cope. We have lined up good amount of pediatric endocrine cases. There's a lot of demand. We would like him to lead some of the cases. We are going to start without. There'll be a slight rearrangement of the program because a few more are coming. Okay, go ahead.
Small admin request. Those who have not registered earlier by call or email, please give your name and KMC registration immediately within 5 minutes. The paper certificates are being sent for KMC for certificate stamping. Please do it now only.
There are a few other people who deserve special mention. One is stand up. They come. He's Prasanna. He has type 1 diabetes, a smart fellow, works for some IT company. He hikes, he runs marathons. He's more active. He's an insulin pumper. And sit down. These two young boys, they will, okay. They're examples of India's future. They're both engineers. They're working, they're finishing the master degree in design in a center called Center for Product Design and Manufacturing. We had the fortune of working with them for the last 1 year plus. I'm glad to let you know that these two young people with their boss, with whatever input, has developed the first prototype indigenous insulin pump for the country. And the estimated cost is $150, the cheapest in the world. Hope we will export it to Australia. They have finished the first one and they've already labeled the pump. The pump is called Yogi, India Balance, I for insulin, intelligent, India, everything. So they may need the prime ministers to help them. Hopefully their dream is within a year or two to get a low cost pump. And they showed me the prototype a week ago. The accuracy of delivery matches a Medtronic pump. It can deliver up to 0.05 units per bolus. But they're also part of an artificial pancreas. Science in this country is slowly catching up. As you see, they're the future of the country. Most of them go abroad and make the discoveries. These two young men have, so they're going to talk to you in between. There is one mother, come, stand up. She's, her son, Abdullah is his name? Yeah, her husband is an orthopedic surgeon. She has a son who has type 1, he's in school. And I've rarely to see a mom so passionate, so alert, and she has come. There may be one or two other people whom I miss, we'll introduce on the way. They've all come to listen. Next Tuesday, this week is the ISPAD conference in Hyderabad. Next Tuesday, we'll have one more friend from Australia. They'll be focused on on-hands pump workshop. Mr. Adam Lamendola is a diabetes educator, pump trainer, very senior in Australia. He comes once a year too. So next Tuesday, all are welcome. There is a hands-on experience with the pump and a little bit. Now, you will go.
Hope all of you had coffee. One. so that we will start the serious part of the CME now. It starts with the first lecture. No, we don't want disturbance. Everybody took. If anybody not taken, please go and take. Yeah. So it's 10:45. We will start the first session with the first lecture by Dr. Shuchy.
Our Tuesday lectures are broadcast live. So if you come on YouTube, even those who cannot come, if they are played in audio metro, they can visit. At the end of the day, the entire proceedings of YouTube, I will say, sorry, speak. Now, since it is being recorded, audio visuals are important. This is the pointer. And when you want to ask questions, you pass on the hand mic. Please. Please speak to the mic, hand mic. Because if you don't speak to the mic, the audience of the cannot listen to it. So we will hand over the mic for the speakers to have a powerful follow mic.
Very good morning. To speak in all the leaders, it's something like you all know these things. It's just from my experience. I hope you'll forgive the things which I repeat and which I do, like which may be wrong, but I'll try to share my experience. This session is on parent counseling and education. First few slides are on parent counseling, and the education part is focused on there are multiple causes of high and low blood sugar levels, which sometimes we may find and which sometimes we may think that the child is doing this or eating more or doing something else, but the child is doing something different. So these are some of the experience. Now, when we talk about parent counseling, we need to understand that when a child is diagnosed with type 1 diabetes, it is mostly a very new thing for the family. Most of them do not know about type 1 diabetes. Now, definitely, we have families who have siblings or second generation. But 5-10 years back, there were very less families which mm, which came to us and say that okay, that they were so surprised how a child can have diabetes. So the basic tool which I feel is positive reinforcement, because negativity, anger, even our frustration and their frustration ends up in zero. And apart from that, when we talk about teaching skills, we talk about taking insulin, taking monitoring, balancing diet and exercise. But this session would be two things: multiple causes of high and low blood sugar levels. Now, as I said, and you all know that diagnosis of type 1 diabetes is not only about insulin. People are afraid of taking insulin because it's an injection, but still, it's not about insulin. It's about insulin, monitoring, diet, exercise, and everyone, as they pass through, insulin becomes the less thing. The other things take a very important role when the child wants to eat, when the child wants to play, when the child wants to go to trekking. And parents are the main caregivers of the type 1 diabetes. It's a 24 by 7. It is a battle, but it becomes a routine when parents understand the management of diabetes, when parents accept that diabetes is going to be there, when parents we are involved in that. So, in Indian scenario, when we say about parents, parents have all the duties from arranging the medicines because it's out of pocket expense. Parents need to go to the doctor, arrange medicines in resource limiting setting. Arranging medicine is also a very big task for parents. Providing nutrition, making them eat that food, cooking to taking it to their mouth. When the child sometimes blackmails the parents that I will not eat, I have taken insulin, but I will not take food because you are not fulfilling my this wish. We have to tackle all these issues and monitoring child well-being because child should be the first is all the parents' duty. All these aspects. Child should grow, child should feel okay, child should be well in studies, child should get married, and child should have children. All our parents' duty in Indian scenario. Along with that, managing diabetes becomes a very huge task. Now, when we consider when why parents are fearful, so I have divided the parents' thought process in various aspects like medical, physical, psychosocial. Medically, parents think that giving injection is a highly technical job before their child is being diagnosed with type 1 diabetes. It's the job of a nurse, it's the job of a doctor. We can't give injections. So teaching them that they can take or the child can take is sometimes very difficult. Parents confuse generally between type 1 and type 2. Most of the parents says, my child is too small. Can't we give some time oral medication? Then we will give injection. They think that, okay, at least till the child is able to help himself, let it be given oral tablets. 80 to 90% of people, parents want to try alternative medicines. There are so many advertisements. The only way out I feel is okay, you try it, but do not stop insulin. If you promise that you do not stop insulin and you are going to give me reports, then you need to tell me everything. I will, because if I say no, they will still try alternative medicine and may put the child's life into danger. And other aspect of parents is there are some parents who create hype on every hypo and hyper. They think that every low blood sugar level is going to be very dangerous. So they keep the blood sugar levels fairly high so that the child does not face any danger. And some parents think that okay, it child is having diabetes, so diabetes is equal to high blood sugar levels, so the child would have high blood sugar levels. Both the categories of parents need to be tackled. That moderation is the best, and in food control, sometimes hypo can happen. Then if we consider about psychological aspects, denial is a very big issue. Many parents think that my child can't have a diabetes. Even I have seen doctor parents saying that it can be a temporary issue, it can be because of some drug, child was eating too much sweets. And most of the psychological data says that it takes around 6 months to 1 year for a parent to accept that the child is having diabetes. Social comments and advices, although useful because we don't have depression that much like as in Europe and UK, but can be sometimes very frustrating when parents are told by grandparents, uncles, and aunts that you are becoming very restless. Why you have tried an injection first? You should have tried something else. You should have gone something else. There is an anger and a frustration of a parent as an individual, and apart from that, if there are other siblings, their issues needs to be tackled. Sincerely speaking, I have seen many siblings suffering because the other sibling is having type 1 diabetes and that child is neglected. As I have grown up, I feel that yes, those children also needed care and those children's feeling also needed. So in CDIC, if siblings come, we allow them to come and participate so that they understand. In fact, diabetes touches almost every aspect of the child. And this cycle goes on and on. Denial, when the parent says that the doctor is wrong, report is wrong, anything, to anger, then they want to go to another doctor, to depression, to bargaining. where they want to try something instead of 4 injections, 2 injections, some medicine, and then to acceptance. Peer group support actually plays a very big role when the accepting diabetes is difficult. Now, when we say about physical aspects, it is true that it's a 24 by 7 job. Results are not good. Even with best of ability, there are some high blood sugar levels, there are some low blood sugar levels. It's a big financial liability. Parents have to, for lower economic status, definitely parents have to spend a large amount of chunk of their earnings to the diabetes management. But even in middle class, parents have to leave some of their desires to manage diabetes because it is a big, huge expenditure for them. It involves the feeling, look, success is nothing succeeds like success. You do something and feel good, you feel that you have to do it again and again. And after doing everything, when the sugars are still high, parents feel frustrated. They feel that whatever we are doing, the things are not going work. So it involves the feeling of failure. It involves the feeling that they are not doing correctly. Lifestyle changes, which we always say for it's for the family, are the most misunderstood. Parents sometimes think that it's the duty of the child to exercise when they are sitting and watching television. That's also wrong. And sometimes parents think that they have to be always on 6 a.m., get up the child at 5:30 or 6 a.m. only to get for walk, even on Saturdays, Sundays, and that makes the adolescent or the child frustrated. So the fun, activity, and the life part sometimes leaves behind when dealing with diabetes. And short and long term complications are real, but they're not as, like, I feel they're not as deadly as they are perceived because people live with diabetes. Social aspects, parents, like as I said, parents need to deal, not in Indian family, they're not only parents, grandparents, uncle, aunts, friends, relatives, they all need to deal with them. They have to deal with their life. As I said initially, it is a very big process for them to learn about diabetes, but we have to make them understand that ultimately it is a balance between parent, child, sibling, teacher, doctor, diabetes educator, and friends. Whole of the responsibility is not there, but the right time and right way of giving responsibility learning is very essential so that the social aspects can be um, kept normal. On the other aspect, child also faces discrimination in school, in playground. When the parents tell teachers, some teachers are supportive, some may not be so supportive. They ask the child. Actually, in my experience, it depends upon the child. If the child is nice, child is good, the teachers accept with the child and make adjustments according to the child routine. The child is slightly naughty, child is slightly stubborn, the teachers also becomes that we can't handle your sick child, and that becomes a double trauma for the child. Um, Sometimes I feel that all children are not so good. They are some children who are slightly naughty. We as teachers, we as doctors need to handle them. But at that point of the time, teachers also become that your child is creating problem. Your child I can't make an adjustment. But if I talk about my personal experience, none of my teachers has never said no to me because I think I was different, other child is different, and the various children face different issues. And parents are concerned about their child with diabetes. Apart from that, we have multiple groups of patients, not so educated parents, working parents. When there's a trouble between two parents, many of cases we have seen that fathers have left the mothers because they feel that the sick child is responsibility of the mother and not the father. And that becomes, and when we meet such parents and mothers and their children, goosebumps occurs how those brave mothers are dealing with this. But again, they have to go for a work, they have to deal for other children. So the problems are joint families, other children, and many other problems. In joint families also there is a big problem that when you say diet, other children may not follow that diet, although it is like repeatedly said that there's no such thing as diabetic diet, it is only a balanced diet, but still that discrimination and the difference occurs. This stress keeps on continuing. Stress on marriage, needs of other children, social responsibilities, other people comments, feeling of isolation and feeling of exhaustion. All are real and all need to be tackled. And I was reading something that diabetes education becomes um, waste in many cases when psychosocial issues are not handled, because psychosocial issues occupy the person's life more than anything. It keeps on continue when the child grows to the adolescence. Child started speaking a stealing or speaking a lie. Child goes from one school to another. Child has to go to college. Parents have their own worries. When to responsible, what to transfer responsibilities to the child. Child is ready. Making the child keeping the child always at home is also a very bad thing. Do not take, like, not taking any responsibility for the child, that now you are an adult, take care, you are now 18, you can do anything, is also wrong. And it's a very big confusion for parents. Sometimes I get a call, is it's a trek at school, should I send my child? It's a trek at college, should I send my child? Definitely you can send. And the other hand, sometimes I get this kinds of call also. Now she's 17, she needs to take care of her diabetes. Till when I will take care of my diabetes? He's still only 17. He needs to grow up. Even for a 17 or 18 or 19-year-old, you don't even marry them off. Worry over upcoming lifestyle stages like long-term health, job, marriage, children. And the biggest question, what would happen to my children after I die, is still the most common question which is asked. Fact remains, children are good observers, not good listeners. Be strong. It's difficult. One day, one mother asked, isn't it too much to ask from a parent to be strong and cheerful in front of a child? I told that parent, it was your option, like, to be a parent, or it was your wish to be a parent. Parents need to be strong. It is not because the child is having diabetes or not having a diabetes. Parenting is the toughest job, and all parents need to take care of multiple things at a time, because children are good observers, they are not good listeners. I was found a joke in that when I asked my child to put the dirty clothes, he went to my husband's side of my husband's bed and put the dirty clothes there, because he thought that the laundry bin is there. So they are good observers. They are not good listeners. So if the parents are strong, parents are cheerful, parents are responsible, this ultimately results in successful management of diabetes. Nothing else. Parents' positivity, doctors' appreciation is the what we say is the key to my life, and I think that works for everyone. So that's the thing. Child counseling needs to be continuous. It's after parent counseling, child counseling also, because children feel that something is wrong. Even a 4-year-old thinks that when my parents are getting worried, I have done something wrong. It has to be age appropriate, it has to be timely, it has to be regular. And if the child is not failing, the child is not falling into the regime, then it has to be by an expert. This is in painting by a type 1 painter, which says, again I lose control. I know it is again and again, you have to control, you can't have fatigue, because ultimately it's your life with diabetes. Always listen first. I think first 5 minutes gives you the crux what the parent or the child is troubled most. Even first 2 minutes gives you. Sometimes it's pain, sometimes it's family, sometimes it's eating, sometimes it's cost, whatever it is. Remember water. Welcome warmly. Ask and assess acceptance. It's very essential that you know that at what stage of acceptance they are. Tell the truth. Without telling the truth, the things can't move forward. Reassure and rehearse the management. Explain with empathy, definitely, because empathy is required, not sympathy. Because child is always, you feel the child is cute, you feel the child is poor, but that would not help the child. You getting into the child's shoes and understanding their problems will help the child. Counseling must be individualized because people are different. Small steps always make a beginning of big success. There's always a way. In most toughest cases also, there is a way. And if even if there is not a way, karmanyavadhikaraste ma phaleshu kadachan. It's a saying by Gita that we have to do our duty. Maybe way will be found by the God in some way or the other. Appreciate. Appreciation works like anything. If the child has HbA1c of more than 10, child is not listening. Sometimes appreciating the child's dress or child's play, something actually helps the child to sit in front of you. Otherwise, they wander somewhere else. You never know when your small effort, when your small kind word can change their world. Again, these are personally my thoughts. They may not be correct, but world cannot be changed by negativity. Has to be a positive reinformation. Children need to forget, need to feel positive, secure, and hopeful. And I like the title of this book, Kids First, Diabetes Second, or what we say, Children First, Diabetes Second. Group education sessions are actually a very big support for our, especially for CDIC children, because when I is replaced by we, even illness becomes wellness. In nutshell, listen to them, identify what they need, let them meet parents in their situation, provide solutions in form of resources of sharing responsibility. Maybe a sibling can share responsibility. Give them a realistic goal. From 10, they can't come to 6.5, but 10, they can definitely come to 9. Let them have an opportunity of having shared goals and in diabetes management. Education needs to be continuous. As I said, that we will talk about multiple causes of high and low blood sugar levels. You all know hypo is considered when the blood sugar level is below 70 milligram per deciliter. All know the signs and symptoms. But what few things which I have seen that in very small children, even inconsolable crying is the sign of hypoglycemia. There was one mother who would say that whenever the child goes to a mall, he becomes stubborn. Otherwise, he's a very good child. That what are you doing in a mall? We are going in shops from here to there. So it's a kind of exercise. The child must be having a hypo. Next time I ask, take the glucometer. At that time, the child's blood glucose level when he started crying when becoming naughty was 50. So sometimes we think that child becomes naughty in the mall to eat, but it was actually his sugars was going very low. One another child, a very small child, 18 to 20 months, was getting up in night and getting like was crying. So they said there was a prasad at home and we gave it, and became okay. So something must be wrong with some intervention. God has helped. So please, you give God prasad, but please check the blood sugar levels, and it was low. And the prasad is generally sweet, so it works. For funny looking eyes, being blank, sleepwalking. One of my friends always started to sing when he was in hypoglycemia during night, blah, blah, blah. And something, and the mother would say that now I recognize that this singing is hypoglycemia. So various children can have these. Hmm. You know what is mild, what is moderate, and what is severe hypoglycemia. Although glucagon injection is available, most of our CDIC children cannot afford glucagon injections. So we ask them to keep a sugar syrup or a paste and trickle it so that the child gets over hypoglycemia. Common causes of hypoglycemia, insulin related, are too much insulin dose. One very funny case was the child was saying that father was saying that my child is getting okay. Look, she's having so much hypos. She's taking just only 8 to 2 from 8 units of short acting insulin. She has come to 2. I think something miracle is happening with the child. We were in doubt what has happened, what has happened. how it can, it has, the child was diabetic from last 4 or 5 years, so honeymoon phase can't happen after 5 years. I asked them to calculate the dose of insulin which they were using. It was like the vial which was finishing in 1 month was again finishing in 1 month only. So I said, when you are taking less dose, it should not finish in 1 month. It should be finishing in 2 3 months. Then they found out, okay, the child was taking injection and taking so that he can get coke and laddu. When we stopped the child, still it continued. That, you have done the right thing. The child is still having hypo. Okay, is there anyone else having diabetes in the family? The child's grandmother was having diabetes and she was using Mixtard. The child was drawing Mixtard and taking it because the hypo was the only thing that can allow him to get the coke. So then we have to add some coke and something in her diet so that we know that what she is taking and what she is doing. So too much insulin is not always prescribed. Too much insulin is also taken by intelligent children who know, who we teach insulin dose correction. In even in our center, one child had sugars at 8 a.m. at 4:25 and then had checked, taken correction dose, and after 2 hours every dose was correct, and for 4 days he had kept the same readings, 123. After that, 5 10 he has checked and made the. And when I asked, why are you doing that? Because I don't want to make anyone sad. When my sugars are high, my doctor, my educator becomes sad, so I take this and do that. Insulin injection time in relation to food. As we know, human insulin needs to be taken 30 minutes before. If the child takes a long gap, or if even in the modern insulins, they give a long gap, intramuscular insulin injections. Insulin injection site overuse, like for example, child taking the medicine in thigh, insulin in thigh, and going for a football match or cricket match, or their different insulin absorption rates, taking wrong or more corrective doses of insulin, and child taking extra doses to have hypos and eat sweets. Diet related, skipping food. Many children skip food because they don't like the diet which is prepared. If in that case situation occurs, it's better to give them the diet which they eat rather than mixed diet, rather not to making them skip meals, having hypo, and then giving them only sugar. Skipping snacks, too late food and snacks, food containing very less carbohydrates. Nowadays, keto diet is again getting very famous, even in Titan circles, because people feel that it will let them have less insulin. I don't know about what it will have effect on pediatric population. For adults, it may be okay. Exercise, unusual activity like walking while shopping, too much activity like playing, too much activity, especially in this season when there's Navratras, when people go for dancing, when people visit other places. Increase of strenuous exercise, sometimes hours later, like lag effect. Unusual exercise and part which insulin is injected, like maybe bowling, even if they have taken arms. So that's why morning and afternoon insulin injections have to be taken in abdomen rather than any other. Illness, gastrointestinal infections, and meningitis can cause hypoglycemia, and alcohol, especially in teenagers. We all know about hypoglycemia treatment. All know that in extreme hypoglycemia, they need to come to the hospitalization. We try that at least the parents know, friends know about hypoglycemia, because hypoglycemia in 99.99% cases can be treated at home if the parents, friends, and others are aware. Hypoglycemia unawareness, when the patients do not feel, the only option is to lower the goals so that the unawareness can be treated over time. People with hypo-unawareness need frequent testing, higher targets for glucose levels, and an ID. Hypos have effect on child, can affect IQ and school performance, are actually the things when people think that the child is sick, because if a hypo occurs in school, if a hyper occurs, sometimes teachers may not notice it. moderate hyper. But single hypo can label the child sick forever in their life, can lead to lower self-confidence, can lead to, can often happen in sleep and exercise. It is a major concern for parents as children cannot always tell that they are going low. Hyperglycemia causes doses related to weight. Many parents think that if insulin doses are increasing, then their child's diabetes is getting worse. Wherever we go, whenever we go, we always teach as the kurta of a 5-year-old should not fit into 6-year-old or 7-year-old. Till your child is going to be 18, the increase of insulin dose is a good sign, because it's a sign that the child is growing normally. You should celebrate it rather than scolding the child. Look, last time your doctor uncle increased insulin, now this time also increased, so you must be eating sweets. Not like that. The last time when you went 6 months back, the child was 11 and a half. Now he's 12. The growth hormones, the growth, the height, the weight, all things have increased. And if you are keeping the same insulin dose, even if the sugars are controlled, the child may have stunted growth. Skipping insulin doses. Sometimes parents do not understand what the dose is, right? So they need to be asked what they have understood and how many doses they are pulling in the insulin. This we have found in many cases. Insulin injection site atrophy and lipotrophy. Dr. Raghupati is completely working on this, because there are many children who have come with so much lipotrophy and their insulin absorption is not at all true. And we have seen that in IGICH, by only working on lipotrophy, HbA1c has come to 1 to 1.5%. Insulin injection mixing, insulin injecting time in related to food. They are just injecting and taking food. In case of human insulin, it has to be 30 minutes before food. Storage of insulin, if it is not done properly and not knowing about corrective doses, is also a big reason of hyperglycemia, because for type 1 correction doses are required. Diet related, not following diet, not lying diet, not liking diet prescribed, taking wrong foods at wrong time, or taking food at wrong time, having only carbohydrate rich diet, wanting to have sweets all the time. My again experience, we need to give them options rather than restrictions. Another thing is child consuming alternative medicines with sometimes sugars or some other doctor can also cause high blood sugar levels. Exercise related, not exercising at all, or anaerobic exercises without guidance. Other reasons: adolescence, growth hormones, fear of hypoglycemia, family related stress. Stress is a very big reason of hyperglycemia. We had a child, her sugars were always high. When asked what happened, she said, I don't have any goal to live. I have only, like my mother and 6 siblings all go for either work or study. I have only left behind. So why should I live? You give insulin, so I am surviving. So I don't feel like the reason of living. So I had to just say the mother, please put her in some work, stitching, beautician, anything. And once the work started, the child's HbA1c started falling and no change in insulin dosage also. Smogy phenomena, infection, taking cough syrup or steroidal and concomitant illness like celiac disease or thyroid disease disorders can also be the reasons of hyper high blood sugar levels. Um, if blood glucose are constantly high, we know that we need to visit a doctor. But if they are one time high, it can be corrected by a correction dose, drinking water, drinking buttermilk, having a longer gap between the insulin and the food. For example, if your sugars are high and you are taking human insulin, instead of 30 minutes, you can take a 45 minutes gap. Or if you are taking modern insulin, taking it 15 to 20 minutes before food can cause high blood sugar levels to fall quickly. Ketones needs, all children needs to know about ketone testing, because if ketones are positive, it needs to be dealt in a different way. Insulin dose correction, you all know, dose of rule of 1800 divided by total daily dose is the base value where we start, that 1 unit of insulin would drop the sugars in that much, but it's the base. it is different at different times. For me, it is different in morning and lunch, then lunch and dinner, because morning my insulin resistance is more. So it varies for, but that becomes the base. That can become the base, and it helps to correct hyperglycemia. Calculating insulin in according with extra carbohydrates is total daily dose, 500 divided by total daily dose. That is 1 unit of insulin covers that much amount of carbohydrate. If you are taking 40 units, so 500 divided by 12 is 500 divided by 40 is 12. So that one insulin will cover 12 carbs. If the child is eating like one gulab jamun, which has around 60 to 70 carbs, then child needs to take 2 to 3 units extra, or he has to exchange it with one chapati as the child feels. Hyperglycemia has also effect on child. It causes the child more prone to acute illness. Children are dull and exhausted. There is more depression. Children are more aggressive and unreasonable when the sugars are high. Few mothers say that I can recognize hyper and hypo because when my very good child becomes unreasonable, that means it's the time the child needs to check sugars. So it would be either low or it would be either high. Lack of concentration. But hypoglycemia and hyperglycemia can happen from time to time in everyone who has diabetes. It can't be like it's not God made, so it's man made, so it will happen. It's essential people with diabetes or children with diabetes and their parents learn about it and learn to treat it also. Sometimes they are confusing, so it is better to check. Both high and low blood sugar levels have an impact on quality of life of a child, so both need to be concerned. Um, Sick day rules. Any kind of sickness, cold, flu, sore throat, we all know can affect diabetes. This means that diabetes is more difficult to control when the person is sick. Four main concerns are high blood sugar levels. Definitely, any infection can cause high blood sugar levels. Low blood sugar levels. Low blood sugar levels can definitely happen when there is a gastrointestinal infection, or but it can happen, or the child is not eating at all and the child is given the exact same dose and it's not monitoring. Dehydration, if the sugars are more, child is vomiting, it can cause dehydration. And diabetic ketoacidosis. Diabetic ketoacidosis is very common when the child is very small and are not taking correction doses. How to preventive actions? High blood sugar levels, check sugars more often and take corrective doses of short-acting clear insulin. Low blood sugar levels, check sugar more often and eat little at frequent intervals. We have to ask the child to take something like a fruit, smoothie, or nimbu pani with sugar, especially when the child is sick and in very small quantities. Dehydration, drink plenty of fluids like buttermilk, soup, lemon water, rest and stay warm, because in sickness, like chances of having diabetic ketoacidosis are much more. Any doctor, we tell the children, whenever you visit to any doctor, tell them about their diabetes. You can't say to tooth doctor that I am fine. Your tooth doctor also should know that you are having diabetes. Over the counter medicines generally have sugar content, so either ask your doctor for first aid or tell the chemist that you are having diabetes, so you need a sugar free option. Never stop your diabetes treatment. Illness generally causes greater demand for insulin. Reduce when you can't eat, reduce rather than eliminating insulin when not able to eat. Follow your regular meal plan, but if you can't eat regular, then eat light diet like what we call as cereal and dal, khichdi, plain curd, rice, banana, other fruits, because actually fruits are easily digestible. Small frequent feedings may be easier to tolerate during an illness and help recover fast. We need to eat because without eating, nutrition would not be there. If the child is eating less food than liquid diet like custard, tender coconut water, milk, soup, buttermilk may help. When one need to go to the hospital, when there's larger repeated vomiting, sugars are more than 240 level despite extra insulin, or sugars are less than 70, even after taking precautions, there are ketones or labored breathing, the underlying condition is unclear, the child or the person is confused, and there is severe or unusual abdominal pain. In nutshell, monitor blood sugar levels more frequently. We have to teach parents home monitoring of ketones. We need to teach about supplementary or correction doses of insulin. Food should not be stopped. Insulin should not be stopped. And whenever there is a doubt, call your doctor and diabetes educator. Most emergencies in the child with diabetes can be prevented when the parents are counseled and educated on management of diabetes. Thank you.
We will take, there are 3 lectures in each session. We will take the questions for all the 3 together. Just give it to Angie.
Yeah.
Just as Angie. Angie, just 1 minute, 1 minute. Just be seated. Are you ready? Oops. One second. Just, I'm taking 120 seconds to give a tribute. Please enjoy the next 120 seconds. Please be seated. It is her heart and creation.
I am Spurti. I have type 1 diabetes. This is Dr. Shuchy, my diabetes doctor.
On an average, type 1 diabetes affects 1 in 500 children below the age of 20 years. Children with type 1 diabetes require insulin for survival. These children require 3 to 4 insulin injections every day, along with diet, exercise, and monitoring.
I am Rashmi. I have type 2 diabetes.
Due to increasing obesity and unhealthy lifestyle, type 2 diabetes is also increasing in children all over the world. These children can be treated with tablets initially and require lifestyle changes. Later on, they may require insulin, but there is a hope. Hope for healthy, better, and bright future for all these children.
These are all my friends. They will tell you how to be healthy.
I take my insulin injection daily without fail. I check my blood sugar several times a day and keep it in good control.
I eat very healthy foods like vegetables and fruits.
I do not eat unhealthy food like sugary drinks and junk foods.
I love football and I never miss my game any day.
I don't smoke or take alcohol. I don't do drugs.
God is always kind to me.
My daughter will conquer the world.
My son is my greatest gift and wealth.
This is my message for all children with diabetes.
Climb high, climb far. Your goal is the sky, your aim is love.
I want to become a doctor like you.
I am a beautician.
I'm a teacher.
I'm a nurse. I take care of 400 diabetes children.
I'm an accountant.
I am an engineer.
I'm a financial analyst. I like riding motorcycles. Insulin pump is making my life easy.
I'm a biotech engineer and a business analyst.
I'm not only a doctor, but a person with type 1 diabetes like you. Children with type 1 diabetes can live long, healthy lives when taken care of.
Together we will reach the stars.
The good news I want to share with the senior people here, this 120-second video won the top award at the United Nations on 25th of September. Spurti went to United Nations General Assembly and got the award. She's on her flight back. Tomorrow she will land. one of the children from the group. It was the only one video on diabetes. Rest were on cancer, mental health, but it won the top award. And you take over.
I'm not sure how to follow that. I don't think I can. It's very impressive. Thank you very much. Sorry? Is it on? Can you hear me? I've got a very loud voice. Oh, I just want to explain the difference between life for a child and changing diabetes in children, because I think people get a bit confused. Changing diabetes in children is a NOVO Nordisk program, and they tend to help children in less resourced countries under the age of 18. Is that correct? And Life for a Child, we support, it's a program that supports children from 0 to 26. So if we're in the same country as changing diabetes in children, we will pick up the 18 to 26-year-olds generally, but it sort of overlaps. And we do very similar things. Life for a Child does education. We help with ISPAD workshops, which is the Paediatric Endocrine group. I've done workshops for CDIC too in other countries. We work very well together. And a lot of people say, why don't you join up and do it together? But we never have for whatever reason. And obviously it's a NOVO Nordisk program, and our insulin is sponsored by Eli Lilly. So maybe that's the reason we don't work together. But anyway, we won't go there. So my talk is going to overlap a bit with Shuchy, but I'm going to concentrate on how each child at different ages copes with type 1 diabetes. So the bits that overlap, I will skip through. So has anyone looked after really small babies with type 1 diabetes? Yes? Yeah? Sure you have. I think people say teenagers are the worst time to have diabetes, and then some people say it's a 2-year-old. I think any time to be diagnosed with diabetes, type 1 diabetes, is difficult. Whatever anybody says, it's difficult whatever age. This age is really difficult because the baby is very dependent on the parent. They need a regular routine. They can't say when they're having a hypo. So the parent has to be very, very vigilant. And that can put an awful lot of strain on the family, as Shuchy says. Strain on the family can't be underestimated. It goes right the way through and right until, they're 40 or whatever. And that goes for all children, I think, even if they haven't got type 1 diabetes. At the upper end of this age group towards 2 is a good time to introduce play to education. I looked after a little boy once who was, he was just under 2 when he was diagnosed, and his mother and father were chasing him around the room trying to get the injection into him, and he was playing up. And anyway, we gave him a teddy, not his teddy, a teddy from the hospital, and gave him just a syringe, and he was stabbing the teddy and having a good old time. And that was actually a turning point for him learning how to give his injections. Sounds very simple, but it really worked. And it works in older children as well. Parents are very worried about inflicting pain, and the finger pricks are often worse than the injections, as we all know. And so you need to give them, lots of hugs and reassurance, but you also have to make sure that you're boss, because you can't be chasing them around all the time when you're working and trying to get off to work and whatever. You've got to make them get into a routine, which can be hard, but it's very necessary. If the child is going to childcare, I don't know if your children in India go to childcare when they're very little. They really do need some sort of identification, and obviously they need some education, very important. And I'll talk about school in a later talk. 2 to 4, this is when I don't know whether you have this saying in India called the terrible twos. When I think there's terrible 3s, 4s, 5s, 6s, it goes on and on. But they do tend to be starting to have a will of their own. And this is when food can become a bit of an issue, and they want to control. And we used to, about 15 years ago, we used to say to parents, don't worry, just feed them before you give the insulin. But we don't do that now. That's all changed, and Bruce might want to comment on that. Pretend play, again, the teddy, injecting the teddy and pretending. And this child can choose, without taking 3 hours, choose where to have their injection and also choose where to put their finger prick. And that starts to get them just thinking about what they're doing with their management. I know it's very young, but it does give them a little bit of control, but not too much. So they have no concept of time. So if you say, you need to eat by 3 o'clock, they have no idea. So parents, again, are the responsible, as Shuchy said, and the identification, again, is important. At this age, there's a lot of variability in blood glucose levels because of growth and development. And under 5 years, they tend to be more sensitive to insulin, but obviously it's very, very individual. If they're going to childcare, they tend to pick up childhood illnesses. So the gastroenteritis that you mentioned, and the hand, foot, and mouth, and all that sort of thing tends to be quite difficult at this age. Teething makes their blood glucose levels go all over the place. Immunizations can mess things up a bit too. And again, years ago we used to have them grazing, but we don't do that now. So they have more regular meals. They also have variable sleep and wake patterns. So in type 1 diabetes, as we all know, is that balancing act. And this is a balancing act because of all these variabilities and growth spurts. Can we just go back? Sorry, the little boy in the picture is from Vietnam, and he was at a clinic that I went to, and I got that smile. Thank you. This little one, I think, is from Ecuador. Hypo symptoms, Shuchy went into this a bit, but they can get very dark circles under their eyes. That's quite a common one. And shaking, sweating, pallid. I'm telling you things you will know. And this aggressive behavior, Shuchy mentioned that. We wrote a book in my previous role called Is It You, Them, or Diabetes? And people looked at me as I was mad when I wanted to call it that. But you don't know whether it's you overreacting, and this goes for parents, not just us, you overreacting, them being a normal 4-year-old, or is it the diabetes and the swinging blood glucose level? So when the parents saw the title of the book, they knew immediately what I was talking about, because you just don't know. And that's what's so hard about type 1 diabetes, I think. I think if I was a parent of a child with type 1 diabetes, I would be hopeless. I'd be a helicopter parent. Do you know that term? So they can be pale, drowsy, irritable, aggressive, and obviously they're too young to pick up hypo symptoms. But towards the upper end of this age group, they can, if they have a hypo, it's quite good to reiterate that how they feel, and say to them, how did you feel, when you felt shaky and funny? And you can't use hypo to a child like this, the word hypo. It's these shaky, feeling funny, not feeling quite right. That's the sort of thing children of this age find it difficult to explain. So it's quite good to reiterate those symptoms, and then they pick them up the next time, maybe, hopefully. And the food refusal, well, we don't do that now, but with the insulin following the meal. Okay. So you said 4 to 6 finger pricks a day, 4 injections a day. How many finger pricks would your children do? Because of the strips. Yeah. And this is the issue, that children in Australia would be doing at least probably 6, wouldn't they? Day. Yeah. And we know that in less resource countries that isn't possible, and you've got to spread the strips out, and you've got to get them to do, one before breakfast one day, and then one before before lunch the next day and one overnight and whatever. So I do understand that it's different. So those are the times ideally you should take them, and rotate the sides of the fingers because they do get really, really sore. And the pads of the fingers, if you keep finger pricking there, it really hurts when they paint and draw. And finger pricks actually are the things they hate more than anything, I think. So this little girl is from Bolivia. Yes. So target ranges, are these the right target ranges for you? I mean, I know, no, Bruce is saying no. They should be much lower than that. But this is, yeah. Right, okay. So this is a less resource country slide. So I get what you're saying, but you have to work it out. So I think here you would be aiming for what Bruce is saying, wouldn't you? The top one. Yes? Yes? Less, yeah. As less as you're able to with the strips that you've got. No. Okay, that's fine. Right, next one. So injections, you can see this child on the right had was injecting into the same place the whole time. And the other day in the clinic, I was sitting with your doctor, and two sisters came in. One was 12 and one was 15. Both had type 1 diabetes. And the 12-year-old wasn't prepared to do anything, wasn't listening to anybody, just sat and nodded and laughed and smiled and all the rest of it. The 15-year-old was very sad. We didn't look at their injection site, but it turned out, we eventually got it out of them, that they're injecting into the same place the whole time. And their HbA1c was really high. And this is in no way critical because of you and what you're doing. We have this in Australia. They do exactly the same thing, particularly teenagers. They just go into the same place because it doesn't hurt. And I can understand that, but it doesn't mean to say it's right. So we had a bit of a chat to them, and talking about parents, that mother burst into tears, and she was absolutely beside herself about the two girls and what was the future going to hold. So this happens all over the world. Everywhere I go, same story. It's usually that age group. It happens. Is this, do you dilute insulin? Yeah. Family support, that's, yeah. I don't want to repeat myself. The 5 to 7-year-olds are busy exploring and getting into trouble. And I found in the 20-something years that I've been a diabetes educator that it used to be 9 to 10-year-olds that used to feel different. But now it's younger children that are starting to feel different. They're much more aware of everything. It's really interesting, the psyche of children. So they can accept it at first and actually feel quite special about the whole thing. Go to school and show and tell and everything's nice. And then they get fed up with it. It's not going away. So then they can feel guilty because they're upsetting everybody. Those two girls, one of the girls that I just mentioned, started crying when the mother cried. Now, she was a bit older than this, but they feel guilty because they're worrying their parents. So there's a whole heap of anxieties going on. But parents do need to set limits, and so do we as health professionals. So they're starting to feel different. This is a great time for children to go to a camp. I know it looks young. I used to run camps in Australia for 5 to 9-year-olds, and they'd come with a parent, and we'd have two separate education for the parents and separate for the children. And it's great for the children just to sit in a dormitory and watch other children doing the same thing as them. It makes them feel so much more secure and good about themselves, and somebody else is going through what I'm going through. It's really, really powerful. So responsibility. So obviously an adult has to supervise. It astounds me sometimes in Australia where parents think that the child's had diabetes for 5 years and they're now 7 or 8, and okay, you can look after it now. They can't because they don't have the thought processes to do it. So you can't trust them to do things because they're children, and you still have to monitor their blood glucose levels. And trouble is, parents, the minute child comes in from school, they'll say, "Did you do your blood glucose?" instead of saying, "Did you have a nice day at school?" And doctors can do that too. They can say, you know, "What's your HbA1c?" and immediately the child's on edge and defensive. So they can do some small tasks, but supervised. So again, choosing the finger prick sites, the injection sites, setting limits, sharing, praise. And it's a good idea at this age, it's when they've started school, is for the child maybe to do most of their care before and after school, and then the parents take over at weekends so they have a break. Because they're going to have this for the rest of their lives. Never going to go away unless we find a cure, which I hope we do. But it won't go away, and they have to get used to it. So it's a huge responsibility for them, but you have to start getting them to do things. They don't have the fine motor skills until they're older, so drawing up injections can be difficult. But they manage pumps in Australia, and I'm sure they manage pumps here. Said all that. Yes. School. I'm going to talk about school in the next session, so I'm not going to go on. School is my passion. I really feel very strongly about school. There needs to be trust between the parents and teachers and the health professionals as well. And the child has to be safe at school. And that can be a problem. Most schools are very, very good, but I'll talk about school. I'll talk about school visits and the resources, and obviously they need identification. And we have problems in Australia where the teachers give the children treats at school, sweets and things, and that can be difficult for the child. So that needs to be talked about, and maybe not use food as rewards, use something else. 8 to 12, starting to separate from their parents and become a bit more self-aware. This is an age where I've found that they can pretend to have illnesses and not go to school. She's nodding. It's quite common. I can remember a child I did a school visit for was being bullied, and they didn't want to go to school because of that. So they just pretended to be sick all the time. So I ended up doing a school visit to the child's peers, which I was worried about because I thought this could make things worse. But in actual fact, it worked out really well. The teacher obviously knew the children better than I did, and he pushed me to do it. And I went and I did a few sort of visual things, and then I got the meter, and the little girl with diabetes ran to me at the front, and then all the children crowded around, and they watched her, and everything was fine after that. I'm making it sound really simple. That has gone on for a while, the bullying. They probably start to become worry about their parents and themselves and others a bit more. And there's so much TV and social media and so much out there that I think they are more aware of what can happen down the track if you don't look after yourself. And that can go two ways. They can either do their care very well, or they can just say, "I don't want anything to do with this, and I'm not going to do it." And then that's when you run into trouble, and they end up that 10-year black hole, we call it, where then they come back to you when they're 20, 21, and they've got complications. Questioning rules and, being cheeky and all that sort of stuff, and feeling different. So their friends are very, very important to them. And it's important that the friends understand, and that sleepovers and things, I don't know whether you have sleepovers here, but if they go to a party, it's very important for them to be involved in all these activities and not left out, because that can really cause problems later on. As I said before, too much, too little, that just means that some parents pile the pressure on the child, and they're doing everything for themselves, making their lunch in the morning and doing everything and being left to their own devices, or, they don't do anything. It's a swings and roundabouts thing. all children with type 1 diabetes are individuals. Every one of them is different. And we have to understand that as health professionals, and parents do too. And they're immature. You may think they're growing up, but they're pretty immature. So sharing tasks, again, weekend, weekday, and step by step, and patience and encouragement sounds so simple. Thank you. School, I'm not going to go through this because I'm doing it later. So they have hypo kits. Do yours take hypo kits to school? A hypo kit with their meter and something to test. It's something to eat for a hypo. Some schools don't. Okay, we'll talk about school afterwards. Okay. This age group, these are some African children. This age group, they tend to be doing a bit more sport. So then you need to watch some testing before sport if they've got enough strips. And poor control may delay puberty. A number of countries I've gone to, there's children of 16 who are, this high because they're under insulinized. Very, very sad. And usually we say the ability to drop insulin accurately is 10 years on, but obviously it depends on the child. What would you say? 10, 12? Depends on the child and the family. Yeah, and what the parents will let them do. Thank you. This boy is from Tajikistan, I think. Camp, again, is good. They've got a better awareness of time, so they can start taking on a little bit more responsibility, but not totally, and recognize their hypos and seek treatment. But that can be a problem at school. If the teachers are not very pro type 1 diabetes, they might think the child is playing up and stick it on, and then the hypo goes untreated, and then you've got problems. Thank you. 13 to 17, this is another challenging time. Making mistakes, taking risks. They want to be with their peers and enjoy life and do everything everybody else does, go to McDonald's or whatever. I know there's a McDonald's here, so I've got that one right. They don't want the diabetes to get in the way, and the diabetes does get in the way. Some teenagers manage really well, but others, this is when they can go off the rails. Again, this is a good time to go to camp if you can get them there. We sometimes have problems getting teenagers to go to camp. But there were some very good, you had some very good teenagers in your clinic the other day who I noticed were going around and talking to some of the younger children. And, just talking to them, and not necessarily about diabetes, but just relating to them, which is really important. Can be a bit moody, as we all know, so that you don't know whether that's the high blood glucose levels, low, whatever. They think they can handle more problems, but half the time they can't. Thank you. This is a camp in the Democratic Republic of Congo. They feel different, and diabetes does get in the way. And they can start worrying about not being one of the crowd. You know how teenagers want to all dress the same and be the same. They're different because they've got type 1 diabetes. And people, essentially, they look well, mostly. So people don't really think, why, what's the fuss? Why are you carrying on like that? So that can be hard for them to deal with. They're worrying about their career and what's going to happen in the future. And, they read about complications, they hear about complications, and some doctors can threaten them with complications. And that is not good. You've got to make them aware, but not threaten them. If you don't do this, you will. I think I'll whip through this. Exams are a big thing with this age group. This is a boy in Jamaica that was at the camp that I went to. So more intensive management, which can sometimes be not what they want. They want diabetes to go away, so they don't want to have a pump. They don't want to have multiple daily injections. Driving is a problem. Do many of do they drive scooters or teenagers? Yeah. Sorry? But yes, so they need to be very aware that they do a blood test before they get in drive. We've had a number of teenagers have accidents, and and they've had a hypo, and then of course they're not allowed to drive for a while. So it's quite a difficult problem. Support groups can just getting together with other young people in the same boat as them is really, really helpful and very powerful if you can get them to talk. Parents, I think if you say, can I help? You know, what can I do? But sometimes they'll just grunt at you and you have no idea what they're thinking. So it needs so much patience on your side, the parent side as well. And communicate, and don't just not, Shuchy said this, don't just knock them when they have a high blood glucose level, a high HbA1c, say, in the clinic. You know, say, well, you know, that is too high. I mean, you've got to say, you're doing the wrong thing. But, you know, we'll get it down by degrees and try and reason with them up to a point, but let them know firmly that you mean what you say. So 17 to 25, I've met a few young people, and there's obviously some in the audience here. This is a girl in, I think it's Nagpur in India, and she's got a sewing machine. She's been supported to do sewing and set up her own business with vocational training by the local Dream Trust that we support as well. So the aging out problem is huge, and we're very often criticised, well, why do you stop at 26? You've got to stop somewhere. We used to stop at, I think it was 21 before I started with Life for a Child, but you have to stop somewhere, and we actually do have some where I get the data sheets back and they're 32, 30, and they're still being supported. But what we're trying to do is encourage our centres to help with vocational training or microfinance in Tanzania, and vocational training here, and Rwanda are the main ones doing it. And they're given some money to start up their own business. So it might just be on a bicycle, given a bicycle, and then they go around all the villages selling whatever, toys, whatever. And also where to live. In Rwanda, they have a 6-month vocational training program where they go and learn a trade for 6 months, which is absolutely wonderful. And they learn about managing their diabetes and how to, I mean, they've got to then buy insulin to live. And a lot of them don't have any families, as I'm sure you're aware. There's lots of parents that just desert their children. There's lots of parents who have 8 children and they just let the one with diabetes die. There's young women who've married and they don't say that they've got type 1 diabetes, and then the in-laws find out, and then off they go. So there's some awful stories around. So they usually have less family support. There may be long distances to come to clinic, which I know you have. So it's very important. So we're trying to encourage that. So that's part of our mission. Thank you. So this is more of the Dream Trust. You can see this boy here has got a motorbike, which he's been helped to buy, and he goes around and sells toys. And I'm not sure, that's a bit of a mixture up there. That's a family. But we get some really heartwarming stories that we want these children to survive, but we want them to thrive. I mean, 20 years ago, when Life for a Child started, children were dying. A lot of children were dying, and they're still dying. I heard the other day a girl in Jamaica died at 19. Awful. But more of them are living, and then we have to help them live a good life. So that's what our mission is. Thank you. Siblings. You mentioned siblings. It's another thing. I'm sorry, am I going on too long? Siblings, I feel very strongly about. Siblings get left behind, and they need to be involved right from the start, but without terrifying them. We, in my previous role, we ran siblings days just for siblings, so not child with diabetes. So we'd have about 10 to 12 siblings, and we used to take them to a wildlife park, and we'd do fun things, and then we'd also talk. We had a psychologist there, and we talked about feelings and how they felt about their brother or sister who had type 1 diabetes. I can remember 2 children that were brother and sister of the child with diabetes, who was the youngest of family. So the baby and the spoilt one anyway, before she got type 1 diabetes. But they were about 9 and 11. And we asked them to tell us some stories. And they told us this story where they all go to the same school. And every time their sister has a hypo, the teachers call them to deal with the hypo. So they cried telling us. We cried when they told us because they were so worried about the responsibility that they just couldn't handle it. So we obviously talked to them and they felt much better. They talked to the other children and all the rest of it. And we had to have a word with the parents because they were probably oblivious to that. So, these things happen and siblings can feel very left out. I always say to parents, I'm sure you do, Shuchy, that you need to spend time with your other children. And so when the one with diabetes goes to camp, spend time with the other children and really make them feel, I'm not saying, spoil them rotten, but just make them feel as though they're special, because very often the one with diabetes just goes to the forefront and everything is about that one. And, some parents have a different diet for that one. They do everything for that one and the others get left out. And that causes all sorts of anxieties and depression in the siblings. So the sibling days I found really useful and fascinating, and I think the children did from the evaluation. So siblings, the one with diabetes can tend to be attention seeking, but also the siblings can if they're feeling left out. They also can be frightened of them getting type 1 diabetes. And often parents, I'm sure you've got parents who test the other ones all the time. And the parents always remember when the one with diabetes got type 1 diabetes. It's like another birthday, but not a nice birthday. So it's a grieving thing, and it can go on forever and a day. So there's this huge issues within families, and some families swim through it, and if the parents are together on stuff, well, it's fine, but if there's a bit of a separation or a mixed family with divorces, it's extremely difficult. So when I say play down the diabetes, I don't mean, forget it. I just mean don't make such a big issue about it. And, try not to make the child with diabetes, the siblings feel guilty, and be consistent. And a lot of siblings want to be involved. If they're left out of even going to clinic, they feel left out. So sometimes it's okay to take them to clinic every so often. And I've said about the special time in camp. Parents and carers, Shuchy went into this. I don't need to repeat this. Less resource countries have got more issues with food insufficiency, financial constraints. I mean, we have that in not food insufficiency, but financial constraints in Australia. But managing hypos. Do you have glucagon here? Do you have glucagon? Yes, they need to do something about that. But that's another worry, that if children going unconscious and children having hypos overnight, and letting go. I think parents all over the world have the same problem of letting go of their parents. I went to Uzbekistan recently, and they brought a family in, and it was a mother and a son, and he was about 15, and he was had his head down all the time, very sad. And the mother was almost in tears as soon as she got in. It was pretty daunting. It was a crowd of people like you, and I was sort of interviewing them at the front. And he said, I said, how do you feel about type 1 diabetes? So can you say one good thing and one not so good? And he said, oh no, it's all fine. Everything's fine. And I knew he was saying what mother wanted to hear, because she was watching him and she was holding his hand the whole way through. He was mortified because she was holding his hand. And I just felt so sorry for both of them. And I said to the mother, have you ever thought of your son going to a camp? Oh, no, he's not going to a camp. He's not going out of my sight. And then I asked about the siblings, and the boy hardly said a word. And I thought there's so much stress in that family. And the parents were getting up every night to do his blood, you know, that's what happens. And okay, it's a negative story, but I'm just saying it all over the world. This is a family in Mauritania. Yeah, finished. So they're in Bolivia. So there's a loss of spontaneity. You know, they wouldn't think now every time before they go out to go out for a family day, they've got to take all the diabetes stuff and it just takes over. Parents need time out, and if they've got close family around that understand, well, that's very helpful, or friends. But sometimes people, there's myths, you know, that you can catch diabetes from granny and all these things. So education is really the key, and talking to other parents at clinic, that is very helpful, so they don't feel alone, and seek support if they're struggling. But most people think, I should be able to cope with this. I'm a parent, I'm strong, I need to cope with it, but sometimes they need extra help. So, my conclusion is that we say that children can do everything their peers can do, and then somebody says, well, they can't do that, or they can't do that, but they should be able to do everything other children can do. We saw a boy the other day in clinic, he climbed a mountain, and he was fine, and that was good for the other parents to see that, because you know, they saw that he could do things. They should grow and develop as other children if they have the right amount of insulin and they can manage their diabetes. We should have the same attitude and expectations as for all children, but we just need to remember the diabetes. Thank you for listening. This is all right.
It's the on this the so is that good? Can we hear that? I can put it higher. Am I able to control it myself? Oh, there it is. Yeah. So, can everyone hear me there? So can everyone hear me there? Thank you very much for inviting me here, inviting me to talk. You can always tell a centre by the patients. They give you such a good insight into what the centre's like. I'd start off by saying that if I could take this centre and transpose it and put it into Newcastle, I'd take it like that. You'd be sitting in the dust. This is exactly the type of centre that our specialists at our centre have dreamed about forever. You have done a wonderful job making this place and making it in a way that you can treat children with and people with diabetes to the best that you possibly can. The other thing I noted was how happy the children and the families. Oh, sorry. Oh, okay. And the other side. How's that? I think that's better.
No. I get you. Okay, it's perfectly.
Yeah, no, that's much better. And the other thing I've noticed while I've been here is how happy the children are to be here and how grateful the families are to be here and how they listen to everything everyone says. And that is a true reflection of a centre that's quality and is, and to me, this is an exceptional centre. In the short period I've been here, I've learned a lot. Thank you. So what I'm going to talk about today is really, rather than being you should do things this way, this is my experience of the world, and part of it is how I actually got to that position. So what I'm going to talk about is why I use intensive insulin regimes, carbohydrate adjusted insulin regimes particularly, and how our centre changed what we were doing to what we're doing now. So as was mentioned, my centre's HbA1c is 7.1%. Our HbA1c for children under 5 years of age is 6.2%. So we work very hard to have tight control. And the reason for this is when I started in diabetes, I thought I was very clever, and I was seeing patients and our outcomes were the same as everyone else. Our average clinic HbA1c was about 8.5, 8.9%, around that range. And then I started seeing things in the literature which made me worry. So what this is the Canadian mortality rate. And it doesn't matter what part of the world you go to, you will see exactly the same result if you look at mortality rates. And what you're seeing is that in someone when they're diagnosed with type 1 diabetes at 30 years, they have a 30% mortality rate. If you get there and you then break it down to what the person's HbA1c was, as the HbA1c increases, the mortality rate increases to the point when you're over 8%, the mortality rate is 20% at 20 years. And what you saw in that American presentation that we saw before was that when it's around 14%, the mortality is 60%. So there's no question that the cause of mortality in children is complications due to hypoglycemia. And furthermore, if you actually look at complications, so this is the DCCT trial, eye complications associated with high HbA1c, renal complications associated with higher HbA1c. And this is the EDIC study again, where once they actually intensify, at the end of the DCCT trial, they started being treated the same, and they had the same treatment, the same HbA1c. But despite that, the people who had intensive insulin therapy continued for 30 years to have lower rates of complications and lower mortality rates. So there's no question that good control is important. And in 2004, our centre decided that we were going to intensify what we were doing. Now, I'm going to talk for a moment about the way I think about insulin action. So if you think about insulin, insulin does two things. It does things when it's not present, and it does things when it's present. So when it's not present, what you have is changes in cell structure, ketogenesis, protein breakdown, glycogenolysis, gluconeogenesis, and cell growth stops. So in answer to the question about should there be low-carb diets in children, the problem with low-carb diets is once the carbohydrate quantity gets low enough, the insulin levels get down to a point where they don't grow. So children with low, they say, no, we don't. So what happens when insulin's around? You get activation of the receptor, and you get changes in cell structure, you get lipogenesis, protein synthesis, glycogen synthesis, glucose transport, utilization, and cell growth. But the big issue here is that when you look at someone, the normal day is not this, and it's not this. It's the cycle where you have breakfast and you go anabolic, then you go to lunch and you go anabolic again, and then after lunch you go catabolic, and then you go anabolic and catabolic. So it's an anabolic catabolic cycle through the day. And there's now a lot of evidence that suggests that this anabolic-catabolic cycle is really, really important. So now if you actually look at this in terms of other hormones, when I think about this, I think about the effects on other hormones. So adrenaline, cortisol, growth hormone, things like GLP-1 and IGF-1. And the reality is that insulin is not the only hormone in the body which is controlling people's blood sugars. We've done studies. We've done studies. We've taken people and we've given them exactly the right amount of insulin. We know it's exactly the right amount of insulin because we adjust their insulin every day. And then we give them exactly the right amount of food. And we know it's exactly the right amount of food because we weigh it. We've got special scales that go down to milligrams. So you have to actually do it in a room where there's no airflow and stuff. And we give them the food and we give them the insulin, then we give them the food, and then we measure their blood sugar. And what we find is that 1 in 10 times their blood sugar will go high. And that 1 in 10 times when the blood sugar goes high is due to the fact that their body's decided it wants to be higher and it's using these other hormones. So you've probably noticed that where you do exactly the right thing and it goes up. And 1 in 10 times the blood sugar will go low. And if you get there and you give people too much insulin, 1 in 10 times their blood sugar will go high. So that's got nothing to do with the insulin you've given or what you've done. It's just, it was going to happen. And the 1 in 10 times when you go low, if you get there and don't give people enough insulin, 1 in 10 times, if you don't give them enough insulin, that will still occur. They'll still go low, that 1 in 10 times. And that's because the body, through things like IGF-1 and GLP-1, has decided it wants that blood sugar lower. And we do traces where we put glucose sensors on normal people, and what we find is that their blood sugar gets down into the 50s. On quite a, most people get down to the 50s once a day. And so having lowish blood sugars is not an unusual thing. And the problem with diabetes is, of course, is that you put the insulin in and you can't take it back out again and that sort of stuff. But if you actually think about what high insulin levels mean in terms of the function of these other hormones, so if you've got something like cortisol around, then if you've got a bit of insulin around, then the cortisol can easily come in and do what it was supposed to do and work the way it was supposed to be. But if you've got lots of cortisol, then you end up with a scenario where there's so much insulin action that you decrease the ability for these other hormones to actually act. And so what this means is the type of insulin regime you use makes a difference. So if we look at twice daily insulin regimes, and I was really excited to see that you guys don't use them, is that their insulin levels are high all the time. And what that means is there's no anabolic state part of the day. They have to eat to keep up their food. They've got higher risk of hypoglycemia, all those things. Whereas if you look at multiple daily injections, which is what you guys are doing, then you get this anabolic-catabolic cycle, which I think is really, really important. I've put down here that I'll give the short-acting insulin and the long-acting insulin at the same time. At our centre, we always do that. And the reason we do that is so that the parent can do the insulin injection with the child. It's supervision. It stops medical errors and things like that. Now, what we use at our centre is what we call multiple daily injections adjusted to carbohydrate quantity. And that came around by looking at insulin pumps. And so what we do is if someone has more carbohydrate at breakfast, we give them more insulin to match it. So we match the insulin to the amount of carbohydrate that the person's doing. And we do that by using these cards. So these cards are the size of a credit card, and the people carry them in their wallet. And so what they do is they'll get there and they say, oh, I'm going to have, and we don't count the grams. We only ever count to exchanges, so 15 grams to an exchange. So we say, oh, they're going to have 3 exchanges. Their blood sugar is, say it's 120. So they go, 3, and they go down to the area around the 120, which is this one here. And so they'd give 9 unit. And we can change the amount of the insulin to carbohydrate ratio. We can change the correction factor. And so that's how we actually do it. And for the hospital, when someone's in hospital, we actually use these sheets so that the nurses don't have to come and ask us what to do with when they're giving injections. So they don't have to ring up the doctor and ask how to give the injections. We got one of these charts for the times between blood sugars, and we use these charts for people between when they do their, so if they've had breakfast and it's morning tea and they do their blood sugar and their blood sugar's high, then we've actually got we use the 0 column on the card. And so that just gives them insulin, or I'll go back, 0 column on the card. And you can see what that means is that they can give insulin without accounting for the carbohydrate. And so have a plan for what to do if their blood sugars are high. So the advantages of this is you actually increase flexibility around meals. So they can sit down and the child can decide what they're going to eat. It allows them to do their blood sugars before meals. They can give more insulin if their blood sugar's high. If you do it where you'd say to the person, oh, just increase your insulin if your blood sugar's high, what you find is they never do it. It's too hard to think about. And our families find that this is quite important, so we don't have to spend much time explaining it to them. So this is what happened with, so what this is a vigorous study with about 20 centres from around the world got together and compared their centres based on HbA1c and another number of parameters, and that's what we were before we started doing this, and this is where we are now. And we've been there for about 10 years. So how did we actually do this? Well, we started off that we made the commitment to do intensive insulin therapy, and that's all. So we started starting everyone on this regime from diagnosis. So everyone starts this regime, and everyone sees at diagnosis sees a diabetes educator, dietitian, and social workers, so that they can learn how to do this and how to cope with all the things that we've been talking about already. And we think that each one of these people is extremely important in the management. So the other thing that we've come to realise is that death from hypoglycemia is extremely rare. If you look at the literature, it's quoted as being 1 in 10,000. My personal experience with dead in bed was I had a boy once and he was about 16 and he really didn't do a very good job with his diabetes. And one day he woke up and his brother had died. And the reality is that dead in bed occurs in people who don't have diabetes. And it's about half that rate, but it's what we think now is that most of these deaths that you see in people with diabetes is actually due to type 1 diabetes. And that was from research from a colleague of mine called Julie Edge and David Danger. So most deaths are due to DKA in children, and in older people it's due to complications, as we were hearing from the Americans this morning. Now, the other thing about hypoglycemia is that what this is again the Bitter study, and what they did was they took the centres that had the good control and compared them to the other centres, the centres that had average control or not so good control. And what they found was that if you looked at an individual person's HbA1c and their risk of hypoglycemia, then if you were in one of the good centres, then you actually had considerably lower risk of having hypoglycemia. So when you run someone's blood sugar in the normal range, you actually decrease their risk of hypoglycemia. It sounds paradoxical, but if you think about what I was talking about with the other hormones before, then it actually suddenly makes sense. So if you get there and you imagine that your blood sugar is in the normal range, all those other hormones work normally. But once you go over a blood sugar of 180, all those other hormones that keep your blood sugar up turn off, and so there's no brakes. And so if you start to go low, you get time to build up speed and you'll hit the bottom. And the other thing that we think happens is that people, when they're running their blood sugar in their normal range, learn how to avoid hypoglycemia in a positive way. So doing things like reducing dose, eating carbohydrates before they eat, all those things. So one of the things we don't do is, or one of the things we do is we don't try to increase people's blood sugar to prevent hypoglycemia. We aim to have their blood sugar in the normal range and give them strategies for how to stop hypoglycemia in the situations where they occur for the person. Blood glucose testing very quickly. The more frequently you test, the better your HbA1c, and the reason for that is that if you do 2 tests a day, then you can actually miss the reality to what's going on, whereas if you're doing 4 or 5, then you're much more likely to see patterns. But the way that people, I wouldn't put this as a reason not to say that the people that you're looking after in the free clinic aren't able to make it, because you guys are I was really impressed by how people were doing it through the day at different times on different days, and we're getting this information. So I wouldn't be sort of thinking that this is absolutely essential, but if you've got people there who can do that many blood tests, then yes, they should be doing it. We set targets and limits, and we set targets and limits for everyone. So our blood glucose target for everyone, regardless of the time of the day, regardless of their age, is 144, and we actually accept down to 163 as being acceptable, but we target 70 to 144. Blood sugars at least 4 times a day, and we go for what we call a low glycemic index diet, with breakfast, lunch and dinner as being the major meals in everyone. So, and the thing about that is it's not just the doctors who know this, it's the doctors, the nurses, the dietitians, the social workers, the families. We make a very special effort to make sure that absolutely everyone in the team and everyone involved in the management understands what we're trying to do. We stop what we call non-responders. So what a non-responder is, and I suspect that everyone here can recognise what I'm talking about here. A non-responder is someone where they come in and they say, hey, and you say to them, hey, you know, the last time I saw you, your blood sugars were really, really high, and we asked you to increase the dose, and here we are 3 months later, and nothing's changed, exactly the same as before. So, you know, what have you done to fix things up? Why didn't you call us? Why didn't you contact us? And so what we may do is we aim to make response part of the actual day, part of the person's standard day. So that chart you saw us with, what that meant was if someone's blood sugar's high, they can give extra insulin to bring it back down again. So there's response part of the day. And we spend time teaching the patients how to interpret their blood sugars and at what stage they should actually do their adjustments. And we make sure, just like you guys do, that they have contact phone numbers in case their blood sugars are running high, so that they can actually contact us to adjust the insulin. We insist that there's parental supervision. Now, what we've got here is unsupervised cleaning of the room. Okay, if you leave an adolescent to it, this is what you'll get. Okay, and it's like that child that we were talking about, that where the son took the clothes and put it on the father's side. Exactly the same thing. If you leave a child to it, there's a good chance that what they'll find is other exciting and other important things in their day. So having the parent involved, make sure that thing happens. It also stops mistakes. So in Australia, there's a legal requirement that every time a nurse gives a dose of insulin, that she checks the dose with another nurse and she checks the dose with the family. And the reason for that is that if you give someone the wrong dose of insulin, then they can have a hypoglycemia, or they can spend the rest of the day high. So by having parents or people check each other, what you do is stop 95% of mistakes. And the thing about that is that there's maths involved with doing your insulin. And so if you get it wrong, if you get it right 99.9% of the time, that means you're going to get it wrong once a year. And so that can be the difference between you having a bad hypo or you ending up in hospital with DKA or something like that. So having the parents check is a really important thing. And we teach the parents how to do that while at diagnosis. And the other thing, and the way we do that is we give them what we call the kitchen table rule. And what that is that the blood sugars and the insulins are done at the kitchen table. So when the family come together to have their meal, the blood sugar's done that then, and they give their insulin then. And mum and dad always help. So they say, let's do the blood sugar and insulin. It's never, have you done it yet? We don't let people say that because that just never works. For safety, for the people checking, and it also gives the child support. To say that these kids, a 16-year-old isn't going to develop into a full human being because someone's helping him with his insulin is just silly. If you get there and ask the 16-year-old, do they know how to look after their diabetes? You will get perfect answers every single time because they know exactly what they're supposed to do. But if you leave them to themselves, you'll often have things where it just doesn't happen. That doesn't mean they can't do it when they get older and they're independent. So, and the last thing is that everyone in our clinic's on board. And what I mean by that is that every single person in our clinic knows what sounds right with diabetes. They know what our targets are. They know what we're trying to achieve. They know what our when people should be giving insulin. They know what foods they should be taking, right down to our secretaries, where if someone rings up and they said, oh, my blood sugar's a bit high, they'll say, oh, that doesn't sound so good. I'll get Dr. King to call you back, or I'll get one of the people to call you back and talk to you about it. And so everyone in the team knows what sounds right. So the social workers know what sounds right, and they can talk to people if things aren't going so well. As I said before, and I won't go through this again, but hypoglycemia is rare. But if you've got someone in the team who's really, really scared of hypoglycemia, say a diabetes educator was really scared of hypoglycemia, and they got there and were telling the families, oh, look, if your blood sugar goes to 80, then there's a good chance that you'll die, then the families will run their blood sugar high. So you've got to have everyone in the same team saying the same thing. And what that means in a lot, so this is really hard. This is the hardest bit of it all, because what this meant was when we decided to do this, lots of people said, I think this is important. And I thought, no, that's rubbish. But I had to suck it up. You understand what suck it up means? I had to suck it up. I didn't have any choice because the group decided what we were going to say, not Bruce. So we all sat around as a group and people said, I think this is important. That 5 people would say this is important. We argued out every single thing that we do. And so we got to the point where every single person in the team agreed with what we were doing, how we were doing it. And what that means is that if you come in as a family and I say to you, oh, your blood sugar should be 70 to 140, and then they come and they see you and they say, oh, you say, oh, your blood sugar should be 70 and 140, and they go and see the social worker and they say, oh, your blood sugar should be 70 to 140. What happens then is you're hearing the same thing over and over again, and you will learn what it is. And more than learning what it is, because you've heard it repeatedly, you get the feeling that you feel that it's true. So if you watch COCAD, so who's got TV? Who's seen a COCAD on TV? Or what they do with ads on TV is they repeat the same ad over and over and over. And the reason they do that is because whether we like it or not, it makes us believe what they're saying. Even if we think it's rubbish, if we've heard it 5 times, we'll think it's true. And so by doing that, what you're doing is you're increasing the learning and you're helping the families believe what you say. So one message from every single person: blood glucose targets, hypoglycemia, insulin strategies, exercise management, supervision. Every person in the team gets the same message. And what that means is that we're all seeing the same thing. Yeah, it's funny, isn't it? Only in America. And this is a picture of what this is the Pasha Bulka. And what this was that there was a big storm in Newcastle, and on this, during the storm, the captain thought he knew better than everyone else and tried to move his boat, and so he pulled up anchor and moved boat, and that's him. He's moved his boat from out way at sea into the beach. So one person by themselves making decisions without the group is not a good idea. So thank you very much, everyone, for listening. Should we all sit out the front or?
We give the audience the mic.
I've always felt that every child has a story to tell, a lesson to teach, and a wisdom to share. Because of all the children I have seen with their stories, their lessons, and their wisdom, I'm here today.
Yes.
If you do the same thing, you will be next to me. Okay? And this applies to all the patients that we see, but more so with diabetes. You would all agree with that. Every child is so different. And what do we say? Control yourself. Control your diet. Control your behavior. Control all the time. Have we applied it to ourselves? Do we control ourselves in the same way as we expect them to do? It's so easy to say that. And if they followed you, you almost will turn them to a yogi, become a saint, and it is not possible. So what I learned from Shuchy, where is she? Not sympathy, but empathy. I remember a girl who asked me, why are you doing so many good things to me? Why are you so much interested to me, in me? Is it because of sympathy or because of your love for me? Without thinking, I said both. She said, I don't want both for an answer. I was shocked. I just want love. I was touched. I was really moved. What she wanted was just love, not sympathy. And what you said is very true, empathy. Okay? And they just want that. They want you to be in their shoes to understand their problem. So that was a very good highlight, I must say, from your talk. I mean, I know we are running out of time. I enjoyed both your lectures. Many useful points, many shared from your own experience. And Bruce King, need not see spiders, but you captured all of us, okay? And I think we'll open the talks for any questions from the audience.
Anybody can raise their hand, I will give the mic.
Yeah.
Sir, will you please explain again the low carb food in children is not good? You explain that cycle. I want to know more.
Right. So I've got to think. So I've got a full discussion by myself and several other people that's just has been accepted for publication, and final reviews have been done. That's going to be published in Diabetes Medicine fairly shortly. But what happens is that insulin is important for growth. So if you think on the most fundamental level, what does insulin do? It tells the cells that food is present. So what happens is the body tells, the insulin tells the food tells the cells that the food is present. So it can then take the food, it can take the protein, it can take the carbohydrate, and it can take the fat, and it can use them to make cell walls and DNA and all those sorts of things, and it can grow. Now, if there's no insulin around, what happens is the body senses that there's no food, and it senses that you're in a starvation scenario. And so what we see when we see our children who are newly diagnosed, what we see is children who have lost weight. They've got hypoglycemia. They've got a whole pile of things going on, and they're feeling unwell, they're nauseated, they're vomiting. And then we do all these things to them, but we do one thing, we give them insulin. What that does is tell their cells that everything's okay. Their cells grow again, so they gain weight. Their ketones come down, their glucose comes back down to normal. And what you're seeing is that insulin has a role more than just glucose. To get there and think about insulin as just glucose is wrong. What you've got to think about is glucose in terms of this is how our bodies work, and this is how our bodies utilize food, and this is how we make cell walls and make ourselves normal and make everything the way it's supposed to be. And unfortunately with a very low, so low glycemic low GI diets can be graded. So you can have low GI diets, which are low carb diets, which are less than 40 grams and less than 20 grams, and what we call ketogenic diets. There's no question that a ketogenic diet has a number of where they're actually, the body is so ketones are a sign that the body thinks it's starving and starting to produce ketones. So if you're at a ketogenic diet, there's no question that the cells are getting the message that you can't grow. If you grow and you're starving, you'll kill yourself. Okay, that's how the body interprets it. So the body stops growing. So in children who are on a ketogenic diet, no question their growth will stop. When they're on an average carbohydrate diet, there's no question they'll be growing normally, but we do not know where the crossover is between at what level the low carbohydrate diet becomes a problem. But there's unquestionably a line in the sand somewhere. We just don't know where it is. On the other end of the scale, the reason the low carbohydrate diets became important was that people with diabetes recognised that if they had high carbohydrate diets, it didn't matter what they did, they couldn't control their blood sugar. And so diet is really important. Having a balanced diet where there's a reasonable amount of carbohydrates, there's a good quality protein, there's good quality fats in there, is very, very, very important. And the problem with the low carb diet is that they do not accept that if you get there and you give insulin before you eat at a dose that's appropriate for the meal that the person is going to eat, that you can control their blood sugar. So what we found in our studies that I described before was that if you give the right amount of insulin before someone eats, their rise in blood sugar after they eat will be 36 milligrams per deciliter, and it'll come back down to normal by 2.5 hours after they eat. So you can control blood sugars on a normal average carbohydrate diet if you give enough insulin up front.
I love all the slides of Raghupati, but there is one slide which I love most. It is concluding slide. It says, even angels need love. Then forget about it.
Bruce showed the picture of a room of an adolescent. I can assure you, The room of an adolescent looks the same here.
I was very worried about that.
That's right. And Angie was asking, do teenagers ride two-wheelers and meet with accidents? Yes, very much so. It's the same. And I was very happy when he said that the clinic in Newcastle looks almost the same as here.
Or not as good.
Almost as good. Problems are the same. I keep telling my postgraduates that the problems are the same all over. And we may be a shade better or worse, but the problems are the same despite all the luxury of free care that's available in your country. Okay. And you?
Thank you. Just one quick question. Either Angie or Professor Bruce King can answer. There is a limit to how many test strips we can give in this country. I think 30 is given. Maybe it's adequate if it's staggered and not done 4 times a day, but once and different times each day. That is not a problem for you people at all. No. And in fact, all medication becomes free once they have an endocrine disorder in Western countries. At least it's in UK. How many of your patients are given the sensors to monitor? Because it's child cruelty to make them stick needles into the fingers whatever number of times. So how many of them get sensors?
Okay, so that's a good question. You want to answer, or you have to me? Okay. So I'd start off by saying that 75% of our patients have HbA1c below 7.5%. And the ones that are above that, it's very rare for them to have a blood HbA1c over 90. A lot of them do not do their adolescence, and for me to think that they're doing 4 finger pricks a day or more is naive. You know, a lot of the times they do, but when their parents turn their back, they're not. So what we find is that people can actually, if you get the dose of their insulin right, they can actually go for a long time giving their insulin the way, if they give it the way it's supposed to be given, they can go actually a long time without testing and still keep good control. So by doing it the way that you guys do it, with it, I've got no doubt that, you know, would you be able to get it quite as tight as we're able to do it? Perhaps not, because you wouldn't be doing the corrections in between doses and things like that, but could you get it close? I've got no doubt that you could. When did we get CGMS? At our centre, really, it was last year for the first time. So all that data I've talked about there was pre-CGMS. But it's become available in the last few months, last 12 months. Our finding with it is that some people, their control has got better, and some people, their control has got worse. So in our centre, there's no difference in HbA1c between people in injections and people on pumps. There's no difference in HbA1c between people on finger pricks and people on sensors. And the reason for that is, as I said, some people get there and they see the sensor and they say, look at that, I'm not getting enough insulin for my breakfast, therefore I'll give myself more insulin. And there's some people who get the machine and say, oh, thank God, I don't have to worry about this anymore, and put it in their pocket. And the thing about blood sugar, I once had a girl, you told me to tell some stories about people who taught me things. I had a girl who'd get there and she'd do a blood sugar and she'd put the blood on the strip and she'd put it in the pocket before the machine finished reading it. And it doesn't matter how many times you do a blood sugar or whether you've got continuous glucose sensor on. If you don't look at the results, it's as if you hadn't done it.
Yeah, you go.
How do you explain that it made no difference whether they did finger pricks or not, or the sensors or not? What's your explanation for that?
So if you've got the dose right, then, and they're giving their insulin, then their control will remain good. It will creep off slowly with time, okay? But so usually what happens is they come into clinic, and I saw some yesterday where the kids had made up the results. So again, I'm glad to see that the children in India are just as original and just as creative as they are in Australia.
Very good.
You know, and so it's not our job to, you know, and so our job is to get there and to look at the books and think to ourselves, hey, you know, he's making this up. He stopped doing his blood sugars. Let's get this back on track. And so if you got there and they'd stopped doing their blood sugars and never did them again, their control would go down and it'd go down, even if they were giving the right, because the amount of insulin they're giving is right for this time in their life, but not later on. So, and with the CGMS, what I'd say about that is if you've got people, we've got 30% of our kids, HbA1c is around 6% or less. And so if you've got kids who've got very, very good control, you are not going, how can you make it better? You know, they've already done the work. They've already done everything they need to do to get their blood sugars to that thing. So having something else show the same results, it's not going to make it better. And as I said, what happened is some people got better and some people got worse. And so it kind of evened out. So we really haven't seen a difference. We're hoping that given time, the more we learn about CGMS, hopefully, the better we'll get some more improvement. But at this time, it's made no difference.
If I may add here, I trained in Sydney,
yes,
the children's hospital there, and I saw multiple pricks, finger pricks being done for the blood sugars, and some children preferred only one finger all the time, and the finger was actually white with the scar tissue. I could call it cutaneous hypertrophy. To that extent, they went on doing on the same thing. And when we said, no, I don't want to do it there, I'll do it elsewhere, I'll insist on doing that. But, you know, I saw no benefit of multiple tests being done because I thought whether you do it 3 days or 5 days or 30 days, it's all the same pattern. The pattern is the same. So what we do, and I would like your comments, we do 3 days in a row, 4 times a day, before breakfast, after breakfast, before dinner and after dinner, because we are using the split mix regime, and 3 days in a row, without changing the dose of insulin, without changing the food intake, without changing the exercise, and hopefully keeping their emotions also under control. The first Friday of the month, the first Saturday, and first Sunday of the month. And we give them 15 days rest. The third Friday, third Saturday, third Sunday, we ask them to do again 3 days. So that comes to 24 blood sugar readings in a month. But if they are at school, 2 days they may miss Friday. Some schools are working on Saturday also. But still 20 blood sugars in a month. So we give them 50 strips for a month, you know. And so for once in 2 months they come and it works out quite well. And we do get a good idea. And I think we are happy with that. If anybody else would like to follow that, I think you will get a fair idea and a clear picture of their control. But we have cheaters. We have cheaters, as you said rightly, and some people from the memory, they write backwards, you know, from top to bottom. You know, so it's very difficult to check with the glucometer also. But we always do a glucometer check to see whether they are lying or. And even in Australia, I found the whole page would have been filled up the previous night using the same ink. So we can detect that also.
That makes it very easy because it's like a Picasso. They've got nice, all perfect, lovely, beautiful, same color, same style.
Anyone else with a question?
So just on the comment, I think that what you're saying is hopefully what I was trying to say before, where with the one finger prick a day, because you space it out through the day, you can really get a feeling for what the person's blood sugar is, whether they're coming in okay at breakfast, whether they're coming in okay at lunch, whether they're coming in okay. And the way you're doing it is the same thing, and you put it together in 3 days, effectively giving them the time off for the other days. And I think both methods are very, very valid. And the only exception I'd have, and I must admit it's only been in the last few weeks that I've become aware of this, and that's neonatal diabetes. And I've got a child at the moment who was born at 1,600 grams with neonatal diabetes. And what we found is that we'll get the control perfect, and 2 days later, he'll have gained 120 grams, so he'll have increased his weight 10%, and he'll need more insulin, and his blood sugars will be going up again. And so we're having to see him every week and change his dose every week, just because and even then we're thinking it's perhaps not even frequent enough because we're having to change his dose so frequently. So in very small children, you can get changes, and the important thing is that the families know that when it's not right, that they ring up and they get the dose adjusted, so that they don't just sit on these higher blood sugars.
We will, to catch up the time, we will take the same questions after the next talk. For next will be the insulin pump therapy. We'll continue the same. Yeah. So, we have a small change. Dr. Reshma has an oral presentation about the work 3 decades in ISPAT. She wants to do a dress rehearsal in front of you, get a feedback. This is her first oral international presentation. The title is Reaching the Unreached. Okay, Reaching the Unreached in Childhood Diabetes Patient, Family and Health Education. 3 decades, challenges, failure, success from India, Disha, CDIC and LFC. Give a small glimpse.
Good morning, everybody.
Good
morning, dear teachers, colleagues and friends. This presentation is actually prepared by sir. I have not rehearsed. See, if I have made any mistakes, please forgive me. Pando tree. Pando is a group of more than 40,000 quacking aspen trees that share a single root system estimated at more than 80,000 years old. Pando symbolizes esprit de corps, spirit of the body. It's the connectedness, the trust, the camaraderie, the fulfillment, the passion, and the loyalty of people to each other and to their mission. In the recent review of New England Journal of Medicine, Dr. Stephen Swenson further emphasized esprit de corps is the single most important leading indicator of patient experience, patient outcomes, patient safety, and patient cost in any healthcare system. Though it looks like a forest, the whole thing is actually a single organism. Every tree or stem technically is genetically identical, and the whole forest is linked by a single root system. Based on the concept of the Pando tree, let me try to illustrate the difficulties in management of pediatric type 1 diabetes in India in resource-limited setting, and to reflect on our 3 decades diabetes health education and self-care counseling efforts, and examine possibilities for further improvement in our Disha Free Clinic. Project Disha thus far has served since 1987 more than 3,000 children through the free childhood diabetes clinic, free insulin lifeline, health education and counseling, and many other activities. Project Disha has evolved through 3 phases. First phase Insulin Lifeline. They were provided with free insulin and syringes. In the next phase, insulin plus ration SHBG. They were provided with blood glucose meters and 5 to 10 strips per month. Basal bolus insulin was achieved in 100%. The current CDIC LFAC enhanced support caters to 386 children, and they're provided with 30 blood glucose strips per month, and limited biochemical evaluations are supported. These are some pictures from our Disha clinic. In our Disha clinic, 95% of the children are having type 1 diabetes. Now let me share my glimpses of some of the activities of Project Disha with perceived effectiveness score and successful implementation score. The first activity is individual counseling, initial continued reinforcement. In 1987, these activities began with the inspiration of Professor M.M.S. Ahuja, father of Indian endocrinology diabetes. These are sessions over the years. Next is group counseling, classes, seminars, and workshops over the years. Next is 24 hours helpline, short-term problem-solving emergencies. Beginning with the single helpline in 1994, the service has expanded to more than 6 helplines, likely representing the world's largest and the busiest program. Various presenting situations for helplines have included intercurrent illnesses and medical emergencies, alarming blood glucose levels, medications or insulin dose and adjustments, general diabetes information, miscellaneous. Next is peer counseling, motivation by achievers and role models. Peers, that is, other children and young themselves suffering from type 1 diabetes, have been an important pillar for Project Disha. Young type 1 diabetes couples with a newborn baby inspiring the younger ones in the audience. Type 1 diabetes peers who themselves are doctors or nurses have been our precious jewels. Next, learning resource materials, age, literacy, language tailored. These have evolved from handwritten storybooks and handouts to bilingual wall posters to printed diabetes teaching guides. And the extensively used teaching video, Diabetes, the Answer in Your Hands. Next is residential camps, learning, fun, and confidence building. This was initiated in 1988. Despite the extraordinary usefulness and demands for such camps, we have not been able to sustain the same in the recent years, primarily due to the logistic reasons. Next, Giving Tree, friend of Disha Stars, support a child. It begins with a simple question to Good Samaritans: are you interested in becoming a friend of a Disha kid? Subsequently, a profound magic unfolds. Next is scholarships grant for education for school and college education. Providing insulin is necessary for survival. However, helping towards formal education and employment is essential for these children to become proud and productive citizens of the nation. Not surprisingly, 80% of our children aspire to become future doctors. Next, mental health clinic, psychology and psychiatric service. Over the last 5 years, we have initiated an in-house weekly liaison clinical psychiatry and monthly clinical psychological service. Important lessons we have learned that genuine empathy and altruism are most important medicines besides psychotherapy and drugs to ensure best optimal mental and physical health of all children and families. This is the Samatvam Love, Care and Share team of volunteers. Let me now share some of the outcomes. Along with 100% basal bolus insulin, children have performed well in SMBG and self-insulin adjustment. Hemoglobin A1C improved in 39% and 23% have achieved A1C of less than 8%. Prevalence and management of nephropathy, retinopathy, and hypothyroidism is likely comparable to the other centers in the world. Self-urine ketone testing is less than 10% and injection glucagon is unaffordable. However, strength of our program is leadership by pioneers in diabetes care and health education in India. Motto, service with devotion. Finally, one of the most important lessons we have learned, discipline, compensation for poverty. Just as a deaf and a blind compensate with increased vision and hearing, the poor can also achieve good health through increased discipline. We have called this as a slumdog millionaire phenomenon, indicating that given the opportunities and support, even an underprivileged can conquer the world. Recent example is the United Nations Award bestowed to one of our Disha children for the most inspiring video, Children with Diabetes Future Stars. Conclusion. In a resource-limited setting, philanthropy-based health education, counseling, and psychological support has improved health and welfare in children with diabetes in our community. To conclude, all this amounts to one African word, Ubuntu. I am because we are. Thank you.
Any questions? Questions, comments? Can you make a comment? Sure, please.
That was very good. Okay, you show the photo, even if it takes half a second, you have to see what it means. You can't make audience to some imagination what that photo is about. That is very important because you lose the audience. We all get lost the moment the photos come without explanation. Let's say one thing. This is the counselor talking to a person. One photo you explain that was the new one. Apart from that, and that Purti photo explain. Takes only half a second. You will not run out of time. Kindly explain.
So it's also a couple. So the next beautiful, excellent, very, very, very good, very.
Questions to sir.
Sorry. So it was an excellent talk, very, very good. And I thought in many respects, very, very clear. I think everyone will understand what you're saying. And the only thing I'd say is it's such a beautiful story that we want absolutely everyone to understand absolutely everything you're saying. So there are a few things that distracted me a little bit. One was the quivering aspens. So aspen actually means quivering elm. So you're saying quivering, quivering. So, aspen means quivering elm. Yeah, so the so that's where the word aspen, the city aspen is quivering elms, like that. So you say quivering elms, quivering aspens, you say quivering. So if you want to use I'd just say quivering elms or something like that, because people may not understand what aspen means. People will understand what aspen means. Oh, okay. The picture of the trees, I understand they were the quivering aspens, but we saw so many beautiful trees down in the park here. I sort of couldn't help but thinking it would be so nice if the picture of the tree was a picture of there's a tree down in the park here that was one of the first. Oh, yeah, beautiful tree. I mean, India's beautiful. You should promote it. And the next thing that sort of got me was you had the star ratings underneath the thing, but you never explained what the star ratings were. And you do need to spend just that moment saying what the star ratings were. Pictures, I absolutely agree with you. Pictures, less is more. So you need to go out through the pictures that you picked out and pick, like there were ones where I could see the story that you were trying to tell, but you would be better off just having that one picture and say, here we see so-and-so, and just a second, and have that tie into what you've just been talking about. So very good talk. I think the timing was good, wasn't it? Very good timing, so perfect. It was yeah. So the pictures are wonderful, but people have to have time to actually look at them and know what they mean. There's so many beautiful slides there, you can go for an hour, I'm sure.
I agree with everything. I thought it was really good. The first two slides about the aspen did distract me a little bit, but I got it in the end. Can I suggest you accentuate the volunteer capacity you have here, as well as the people that you pay, because the volunteers are they're the real backbone of the centre as far as I can see, and I'm not knocking anybody else, but I really think that's important because that will help other people from other countries like India to understand how to get a centre like this. Agree? How to do it themselves, because having been to a number of countries that don't have a centre like this will really inspire them. And I really want you to get that across. And also, you said about the language and the literacy. The Kannada, the Life for a Child Education website has got a Kannada page. So we need you to send, but if you want to mention that, that's absolutely fine. But I just want to help you improve the literacy because you've got some resources that we can put on that page to help other people. So that's just an aside. And I love the Slumdog Millionaire reference. I really like that. That's really good. And just to let you know that Life for a Child will support one camp per centre for about $3,000 US. So that would help you start one camp. That's nothing to do with your presentation, but that would help you support a camp. So you need to write to us.
Okay, definitely. Thank you.
Is it per year? Is it per year? One camp per year or one time? One time.
Accidentally, we happened to come across, I didn't know what was Pando, nothing. That forest is one or living organism. Basically, say we have to work together. Alone, we can't do it. And it's amazing. This is a New England Journal article, not an ordinary thing. He has evaluated healthcare, and only when the people are connected to each other and also love their job, it works. And this is a recommendation to all hospitals. Harvard one. She will rehearse. She will make it crisp. Okay. ಇದೆಯಲ್ಲ Okay.
Great photos. Too many.
Okay.
Too busy.
Okay. So we cut down some of the multiple photos, the one with the meaning. Okay. Thanks a million. Now we have to get. Now we'll go to the insulin pump. Right. One second, Amma. One second. Amma, then he will have to come one more time. We'll just do the insulin pump part. Please. Please. No, please, I'm teacher. Somebody else. No, it's okay. We'll do that, please. I will do that. Please, insulin pump. After the insulin pump. Excuse me, after the insulin pump, we'll take a break. Then come back and then Q&A starts. We will cover the syllabus.
Okay, so in order,
100% silence all the way from Australia. Insulin pump.
okay, thank you very much. So I've been doing insulin pumps now for 18 years, and at where we are at the moment is with the multiple daily injections. We originally designed that, calling it the poor man's pump, because in Australia you had to pay for the pump yourself originally. But and so what we're finding as time goes by is that there's a certain, because we get the same results in pumps as we get in injections, there are people who want to be on pumps and there are people who want to be on injections, and it comes down to a very personal choice from the individual as to which one they want to do. And because of the way we give the insulin for multiple daily injections, a lot of the things I'm about to talk about actually apply to injections as well. So what I'm going to talk about is how pumps work, basal rates, meal boluses, correction boluses, insulin on board, blood glucose targets, and then finish off. So how do pumps actually work? Pumps were first described by a chap called Metcalf in the 1930s, and he was a medical student who infused insulin over a few hours and showed that he was able to get metabolic resolution in the people with type 1 diabetes. They then went on, and you may have seen these pictures where they had a mobile insulin pump, which really wasn't practical. This was around when I was young, in about the late 1970s, early 80s. Well, really in the 70s it was around. And then they got to the pumps that were much, much smaller. And pumps that we have now really are very small. And the thing about them is they allow action. So these people, the fact that someone's wearing a pump doesn't mean that they can't be involved in sports, that they can't be running around and doing things. And you can drop them and they don't. The pump that he had, I used to have a demonstration, one of those in my room, to show people how robust they are. And what I'd do is they'd say, I'm worried that this is going to break if my child uses it. And so I'd pick up the pump and I'd throw it so it hit the roof and then go down and bounce on the floor. And after about 3 or 4 years of doing that, I broke the cap on it. But other than that, I didn't break the pump, I just broke the cap on one end. These are made out of motorcycle helmet material, so they're actually really very, very tough. Now, everyone likes to think that pumps are highly technical things, but really what we're talking about is really something that's not that technical. What you've got is you've got a power source. Do you have windmills in? Yes. So you have a power source. You have a pump, And then you have tubing, which takes the insulin to where you want to be. And literally, that's all a pump is. The only thing that's different is that there's a control mechanism. And when you use an insulin pump and you're giving insulin before your food, then you get this pattern that we were talking about before. And the main advantage is that they are very, very fine tuning at any particular point in the day. So the bottom line is that pumps are dumb. They don't do anything by themselves. They're controlled by the user. And it's the user that really makes the difference as to whether or not a pump works. So I'm going to talk about the settings in the pump now and how we set them up. And one of the first things that we do is we set the time so that it's on a 24-hour clock. And the reason for that is the first few times I was doing this, what I found was that people were going low through the night and high through the day, and we were adjusting the insulin, and they were getting worse rather than better. And what it was that instead of we had the clock turned around, and it took us it took us a couple of times before we realised. But now as a standard practice, we always check the clock when someone comes into clinic. That's one of the things we always do to make sure the clock, especially if they're having any problems. There are three different pump settings of importance. There's the background insulin or the basal insulin. There's the meal bolus insulin, or which is the insulin that covers the food, which we call the insulin to carbohydrate ratio. There's a correction factor, which is the insulin to correct high blood sugars and bring them back down to normal, and that's what's sometimes called a sensitivity factor. So when I think about pump settings, I think about the pump settings that we use when we start people on pumps, and I think about the settings that we have once someone's on the pump. Now, the thing about the starting settings when you're starting someone on the pump for the first time is they need to be safe. You need to avoid hypos, because if you put someone on the pump and they're hypo, they're going to hate the pump pretty quick. And the pump must be set up in a way that makes it easy for it to be adjusted. Now, this is how we set up our pump. So we use all the rules. So when I started pumps, what I found was that two people came into my office almost one after the other with the pump and said, I want you to start me on this. And so I was forced to start them. And when I looked in the literature, there was nothing about pumps. And so I couldn't, so what I did was took the standard thing, which was the 150 rule and all those sorts of things, and tried them. And I just about killed the first two patients that I did it on, because it didn't really work that well in kids. And so what I did was, over the next 5 years, every patient we had, we started off, we made up this table, and then we adjusted it as the years went by. And so this has been revised really quite heavily for the first 5 years, and now it still occasionally gets the occasional tweak. But what we find now is the only time we ever have any problems with our starting doses of insulin is when we don't follow this table. And it makes it very easy, because the nurse, the family can come into to start the pump. The diabetes educators can see them, and they almost don't need to talk to the doctor. So one of the things that I do when we start the pump is I set up the times on the basal rate. And what I do is I set the times up to match the times when people are doing blood sugars. So 000 is the time when all pumps always start, which is midnight. So that's a set thing. 3 o'clock in the morning is when people are likely to have their lowest blood sugar. And so we have a time set up for that. Breakfast time, 3 a.m. to breakfast is the time when you really need lots more insulin. Then so our kids, they go from breakfast to morning tea and often do a blood sugar, morning tea to lunch, lunch to afternoon tea, afternoon tea to dinner, dinner to bedtime, and then through to midnight. And what that means is if someone's blood sugar is good at 7 o'clock in the morning and then high at 10:30, there is one basal rate that they can change. If their blood sugar's okay at 10:30 and high at lunch, there's one time that they can change to fix it up. And so, and when you talk parents through what you're doing and why you're doing it, it takes them 2 seconds before they understand what you're doing. So each one of those things corresponds to a time when the family can adjust the pump. So the thing about pumps, and this is a big difference between what we used to think with twice daily insulin regimes, is insulin pumps use rapid acting insulin. And the thing about that is the insulin does not build up. So if you make a change to the pump and it doesn't work tomorrow, it's not going to work in a week's time. So if you make a change and it hasn't changed, you change it again and you change it every day until you get the rate right. Now, what I'm going to talk to you about now is what I call the Dr. King rule of 2 pens. Now, the Dr. King rule of 2 pens only works if you use pens. It doesn't work with pencils. So you'll see what what I mean in a second. So this is one of what we commonly see in one of our clinics. I've changed it to milligrams per deciliter, but what you can see is at dinner time, if we look at dinner time, there's some funny readings there, and you can't really work out whether you've got it right, whether you've got too much or not quite enough. And so what you do is you do the rule of 2 pens. And what you do, and I talked before about how 1 in 10 times the result would be high and 1 in 10 times the result would be low. So what you do is you take the pen and you cover up the highest blood sugar. That's the one that's happened by random chance, so you can't see it. And then you cover up the blood sugar that's the lowest one, because again, that one hasn't had anything to do with what you've been doing. And what you see left behind tells you where you are. And you can look at that and you can say, wow, geez, I'd be happy if that was my child. I'd have 10 of these children in my clinic. That's perfect. So then if we go and we have a look at breakfast and we do the same thing, what we can see is that the child's coming in high. And so we then get there, but if you go over and you look at the 3 a.m., you can say, well, actually the 3 a.m. is perfect as well. So the problem is between 3 a.m. and breakfast. So that's the 3 a.m. to breakfast slot that we were talking about. So what you do is you go in and you increase the basal rate by 1 click. And by 1 click, what I mean is you go in to the basal rate, there's the arrow you set up at that time, and you all understand what I mean, and you do 1 click up. You don't do 2, you do 1. And so you do 1 click up, and what you find is the next day it hasn't got better at all because it hasn't been a big enough change. So you do it again, and you say to yourself, still a bit high, so you increase it again. And because you're changing it every day, that means is you change it quickly, but you don't get into any trouble. You can bring it down to, and what you'll find is it will literally go like this, where one day it'll be too high, and the next day you'll say, that's where I want it to be, it's looking good. And you can go, and then you just watch it for a couple of days, and if everything's fine, you keep on going. So 1 click at a time, because the changes are small, you're not going to get into troubles, etc. The other thing I say to people is, if things are really bad, you find the time of the day that's best, and then you change the rate that follows that. So if you're coming in perfect at breakfast time and the rest of the day is rubbish, then you start your adjustments from breakfast time and you adjust it once at one time frame at a time. So you'll fix up breakfast to morning tea to lunch, lunch to afternoon tea, and you think to yourself, that's going to take hours. But this is like throwing a rock in a pond. If you got there and you've got one time that's not right, if you throw the rock in the pond, it bounces through the rest of the day. So if you've got a time of the day when you're going hypoglycemic, then that will upset the rest of the day. You'll bounce the rest of the day. Or if you've got one time when you're going high, so what you'll find is that you do 1 or 2 time frame changes, and it'll suddenly just go boom, straight down into a really kind of nice tight thing. With our meal bonuses, what we found over the years, we don't adjust according to a sum or anything like that. We adjust the pump according to the patient. And what we found over the years is that most of our kids end up on about 30/70, sometimes it's 40, 60. It's almost never 50-50 basal rate to bolus. If you've got children, children do two things. They run, or and they do lots of sitting. So what happens is they'll eat a meal and then they'll be running around. So if you get there and you give all their insulin, most of their insulin with their food, what that means is when they're running around, there's not much insulin and you stop the hypoglycemia rate. Okay, so we actually have really quite low basal rates through the day and really quite high insulin to carbohydrate ratios. And what we find is that the kids will get there, they'll go up 2 millimoles after they've eaten, their blood sugar will be normal, they'll go around and they'll run around with blood sugars of 70, 80, things like that, and they won't have hypoglycemia. So this is how we adjust the meal bonuses, the ICR. What you're seeing here is that the ICR is obviously too high. You get there and say, well, actually, some of the blood sugars are normal, and that's where the 2-pen rule comes in. Good. Again, you can look at it and say, well, there's too much insulin for breakfast. And here, there's not enough insulin for breakfast. And again, if you get there and you could look at that and say, well, that blood sugar, those two blood sugars there are okay, but when you look at it as a whole, so you can't adjust the blood sugar based on one blood, you have to have an idea of what's going on in general. So I usually only have 1 to 2 insulin to carbohydrate ratios in the 24-hour period. The highest one, if there's 2, then it means the breakfast one's the highest and the rest of the day are usually lower. The families, I just get them to adjust the basal rates if there's things wrong, and I usually do the bolus rate adjustments, but some of my friends do it the opposite way around, where they do the basal rate adjustments and the families do the insulin to carb, but I find this way works really well because the families understand the basal rates really easily. The more bolus rates, what I find is the harder it is to adjust. So the more settings you've got in a pump, so if you've got lots of settings for your basal, and then you've got lots of settings for your bolus, it just confuses parents and they just don't know what to adjust. So you give them something that they can adjust that's nice and easy and it kind of works. The correction factor. Now, here we're getting into the really, Bruce is a bit weird stuff. And we thought about the correction factor for a very, very, very long time. With the way we run our pumps, the reality is that we don't have that many hyperglycemias. People get a few each week, but there's not very many. And when they get a hyperglycemia, it'll mean that something's gone wrong. Either the pump stopped working or they've eaten too much or something like that. And they need to be given enough insulin to bring their blood sugars down, or they'll be sick or something like that. So the majority of what we're doing here is we're aiming to have our correction factor so that if someone's becoming sick and they're starting to make ketones, this will effectively give them an insulin infusion. And so what those set up, this ends up being 20 kilo child will get 2 units if their blood sugar is 300, 300 or something like that. And he'll get 3 units, and he'll get 4 units, he'll get 5 units, he'll get 6 units, which means that that's enough to get rid of ketones and treat DKA if that's what's occurring. So we never adjust the correction factor if people are having high blood sugars. If you're having high blood sugars after meals, it's not because the correction factor is wrong, it's because your insulin to carbohydrate ratio is wrong. If your blood sugar is going up before meals, it's because your basal rate's not wrong, not right. So we rarely, if ever, adjust the correction factor. Insulin on board. Insulin, all of the insulins, even the very, very short, quick-acting insulins such as glulisine, last for 5 hours. So if you talk about insulin duration on an insulin pump, insulin duration, you're talking 5 hours. But the problem is that if you're, sorry about that, that's 180 milligrams per deciliter. If your blood sugar is over 180 milligrams per deciliter after a meal, 2 hours after a meal. So a meal, it should go up 2 millimoles, then come back down to normal about 2.5 hours later. So if you're over 180 millimoles per deciliter 2 hours after a meal, it means you haven't got enough insulin. And so you need to fix it with an appropriate dose. So you need to have, be able to give insulin at 2 hours after someone eats. If they've got ketones, then you need to be able to give an appropriate dose of insulin every 2 hours to get the ketones down. So insulin on board, we use that not as this is how long insulin lasts, because it isn't. It is how often do you need to give the insulin to control the blood sugar. And what we find is that 2 hours is optimal. So blood sugar targets, we tell patients what we expect from them and what they can expect from us. Therefore, the target we set in the pump is like telling the person, this is what we want your blood sugar to be. So if you set your blood sugar high in the pump, then that's the way they'll interpret it. So we actually set our target in the pump at 63 to 108. Now, 63 might sound low, but in actual fact, if you take 100 people who don't have diabetes and you make their blood sugar 63, 2 of them will feel hypoglycemic. The reason they say 70, and this is really out there stuff, is because that's a round number and the Americans can't cope with. So I'm very happy with 70, but we tell people that the target is 70 to 108. But you know, if their blood sugar is slightly below that, we don't get excited about it. If you set the target at 90 to 140, then what will happen is their blood sugars will never really get below 140 because they'll perceive that as being the target. And if your blood sugar is 70, the pump will take insulin away. So instead of being able to keep your blood sugar in the normal range, you will actually make it harder. So we set that range because that's where we want it to be. Now, this is a comment about plastic cannulas. Now, when I started this, when we ended up with 100 patients on insulin pumps, what would happen would be I would get a phone call absolutely every single night. In fact, we got up to about 200 patients on pumps, and I was getting 2 to 3 phone calls every single night because what would happen was their blood sugars were high. And what you're seeing here is site failures because of pump kinking. And it doesn't matter what brand you're looking at. Friends of mine, Wheeler et al., did studies and they'd showed that 9% of all plastic cannula insertions kink over and obstruct at start. And what that means is if you're putting a cannula in every 3 days, then every 30 days you will have a site failure from the start. And every, 30 times 300 days, you're going to have an episode where you put in a cannula, it fails, then you're going to recognise something's wrong, change it, and that cannula is going to fail, and you're going to end up in diabetic ketoacidosis. And for that reason, we only, at our centre, ever use steel cannulas. We never use plastic cannulas because they don't kink. They don't cause as much pain because what you don't see here is that length of that cannula there is the same as that, and it's actually narrow and smaller. So the cannula is actually smaller. We find that people who have pain